Hello everyone. So today we'll be doing obstetrics and gynecology. Just a second. Yeah. Yeah. So today we'll be doing obs and gyne revision for FMG, for the upcoming FMG. Today basically in dedicated 2 hours we'll be doing all the recent obstetrical questions. So 2 hours we can do the obstetrical questions, which is forming the most important part since last many years of OBGY. Okay, so we'll be focusing on last 3-4 years of questions and the related topics with these questions. Okay, so it is gonna be what I say, a very concentrated class, so be very focused. Yeah. Okay, starting with the CTG pattern. So there was a question in 2024, what is this CTG pattern? Now CTG is, what does CTG stand for? It stands for cardiotocography. So we are tracing two things. We are tracing the fetal heart, and in respect to the uterine contractions, how the fetal heart is responding. That is toco, the uterine contractions. So how the fetal heart, which is this, is responding to the uterine contractions, that is CTG. Now CTG has three kinds of decelerations. One deceleration is the one that starts immediately with the contraction. When the contraction starts, the deceleration starts. Not a very good thing, but yes, that's what happened. जो एक्सटेंशन कॉर्ड है ना, उसको यहाँ पे दे देना, यहाँ से. ठीक है. So the deceleration of fetal heart starts exactly with the uterine contraction. Their peaks correspond. So when their peaks correspond, it is called as early deceleration. So always look for the peak, and if they are on the same time, it is early deceleration. Late deceleration is uterine contraction starts first, followed by the deceleration of fetal heart. We call it late deceleration. वहाँ से वो निकाल लेना प्लग, मेरा प्लग ये रहा. ये लगा ना. थैंक्स सर. आ गया. थैंक यू. Hi everyone, I'm happy to see you all, and hopefully this class is gonna be very useful to all of you. Yes, so we were talking about decelerations. I said whenever the decelerations comes, whenever the CTG comes, match the peak of the contractions and the deceleration. If the peak is matching, that is early deceleration. Early deceleration as such not very dangerous. It is seen due to the fetal head compression. When in the labor, the baby head is trying to go inside the pelvis. Due to the fetal head compression, we see the early deceleration. Late deceleration means the deceleration is little late. Uterine contraction comes first, followed by the deceleration. So deceleration is little late. It is something not very good. It is seen in case of fetal hypoxia. When there is chronic fetal hypoxia, then this deceleration is seen. It is called as late deceleration. The last one is variable. It is not related to contractions. Contraction coming, not coming, doesn't matter. There are decelerations. So when the decelerations are not exactly related to the contraction, that is variable deceleration, and it is seen in case of cord compression. So please learn each deceleration and learn each pathology also where these decelerations are seen. Now let's get back to the question. This was our question. Now let's match the peaks. This is my deceleration. Is the peak of this deceleration matching the peak of the uterine contractions? Yes, they are just coming on time. So it is a case of early deceleration. Okay? And early deceleration is seen in, where do we see early deceleration? Early deceleration is seen in fetal head compression. Variable deceleration. Where do we see variable deceleration? This is a last year question. Variable deceleration is seen in cord compression. So very important, since last 2 years the questions are being asked on the type of deceleration and where do you see that. Okay. Now last year there was a question on malaria in pregnancy. Again an important point, very easy. Dekho, when malaria in pregnancy comes up, you always have to see what type of malaria it is. If it is vivax, ovale and malaria, Vivex, Oval and Malaria. All three of them can be very well treated with chloroquine. And chloroquine is safe in all the 3 trimesters. So if it is first trimester, second trimester, third trimester, you can safely give chloroquine. The problem comes when it is P. falciparum. P. falciparum is chloroquine resistant. So we don't use chloroquine. The treatment of choice for P. falciparum is artemisinin combined therapy. Artemisinin combined therapy means we combine 2 artemisinin drugs. Artemether, arteether, lumefantrine, we combine them. But they can be used only in second and third trimester. So what do we use in first trimester? Quinine and clindamycin. Okay? If clindamycin is not available, we can only use quinine also. So remember, for P. vivex, malaria and oval, answer is chloroquine. For falciparum, you have to see which trimester it is. If it is first trimester, quinine. If it is not, it is artemisinin combined therapy. So malaria vivex drug is, for vivex the drug is chloroquine. Okay? For falciparum not. Okay? If you have any doubt, you can always ask me. Okay? I'll be happy to help. So this was the last year question. Now, physiological changes in pregnancy. This central line, can you see the central dark line which is seen in pregnancy? What is this central dark line? There are 2 options, linea alba or nigra. Good. See, it is dark. The dark word scientifically stands for nigra. The word Nigerian comes from dark. So this central dark line is linea nigra. The central line which is generally there and it is not dark, very prominently seen in children, that is linea alba. Okay? It is not seen in pregnant women. It is seen in anybody, especially in children. But once this woman becomes pregnant, this line becomes dark because of high melanin. And now it is called as linea nigra. So mark linea nigra, not linea alba. It is not a white line. It's a dark line. Okay? It is a sign of pregnancy. Good. Now, just according to linea nigra, what is happening is because of high melanin, there is darkening of various areas. Similarly, there is darkening of the malar area. What do we call it? We call it cloasma. Cloasma, or also called as pregnancy mark, is another skin change that is seen in pregnancy. So one is linea nigra, one is cloasma. Third thing which is seen in pregnancy is stria gravidarum. Okay? Which is nothing but the stretch marks. Stretch marks formed due to the separation of collagen fibers. When the abdomen is increasing, the collagen fibers underneath, they stretch, resulting in stria gravidarum. So these are the 3 skin changes seen in pregnancy: linea nigra, stria gravidarum and cloasma. Okay? Okay? Oh, is it so? You don't get the PDF? I can assure you, once the class is over, as soon as it is over, I will straight away give the PDF to the respective people and I'll make sure that they post them here. Okay, don't worry. I'll myself make sure that the PDF is posted here. Thank you for telling. Okay, we'll make sure of that. So these are the skin changes in pregnancy. Related to uterine changes in pregnancy, what question can be asked? The change in the fundal height. As the pregnancy is increasing, obviously the fundal height is also increasing. Please pardon me for the tea. It's so cold that I just can't do without a tea. So various fundal heights that can be asked in your exam. Remember, uterus is inside the pelvis till 12 weeks. Uterus comes out of the pelvis after 12 weeks. So uterus becomes an abdominal organ. It comes in the abdomen at 12 weeks. Uterus reaches the umbilicus at 24 weeks. Please do not mention it reaches the umbilicus at 20 weeks. No. The recent guideline says that at 24 weeks, it is up till the umbilicus. It is at highest point, means at the xiphisternum at 36 weeks. At 36 weeks, it is at highest point, which is the xiphisternum. At 40 weeks, it comes down again. At 40 weeks, it's a lower level. So here it is at highest level at 36 to 38 weeks. So it becomes an abdominal organ, 12 weeks. It reaches umbilicus at 24 weeks. It reaches Zivi sternum at 36 to 38 weeks. Okay? Now, continuing with the various other changes that happen in pregnancy. We dealt with the skin changes. Now, let's go ahead with the various blood parameter changes. What is the most common cause of thrombocytopenia in pregnancy? Thrombocytopenia means platelet counts are falling. You know, in pregnancy, everything is falling. Why? Because of significant water retention. In pregnancy, women retain extra 6 liter of water. Extra 6 liter. Because of this extra retention of water, the concentration of everything falls. The hemoglobin falls, jise what we call dilutional anemia. So hemoglobin fall. Similarly, thrombocytopenia. Similarly, the platelet levels fall. So the reason for the fall in the platelet levels is gestational thrombocytopenia. Means it is physiological. There is no problem. There is no pathology. It is physiological because of dilution. We call it gestational thrombocytopenia. Similarly, concentration of everything fall. Serum creatinine fall. Serum urea fall. The protein concentration. The concentration of protein fall. If you talk about the total protein levels, it increase. Why? Because extra protein means extra muscles mother is gaining, extra blood, baby, uterus, everything is protein. Total protein is rising, but the concentration of protein is decreasing. So everything concentration is falling because of water retention, and we call it gestational. It is physiological. Okay? So yes, not ITP, it is gestational thrombocytopenia. Okay? What about coagulation? Remember, when a question is asked, pregnancy is a hypercoagulable state. Okay? So hypercoagulable state means there is a tendency of coagulation in pregnancy. So what will you write about all coagulation factors? The coagulation factors rise, except two factors. Two coagulation factors that don't rise, they fall. Factor 11 and factor 13. So remember, all the coagulation factors rise, but factor 11 and 13, they fall. What about anticoagulation factors? Factors that will prevent coagulation. Anticoagulation factors fall because pregnancy is a hypercoagulable state. So anticoagulation factors fall, like protein C resistant develops. Protein S fall. Antithrombin 3 fall. So when the question is asked what falls, what rise, remember, anything that prevents coagulation, that fall, and the coagulation factors rise, except factor 11 and 13. Okay? We are here to just quickly revise everything we know. Just going through the questions and revising everything we already know. We are here to just clear the concept, not go into the detail, but yes, just see whether you have the correct information, and also you have all the important information related to that topic. That is what the purpose of this class. That much we can do in these 2 hours. Okay? Now let's see the cardiovascular changes. What happened in the cardiovascular system? What will happen to the cardiac output? What will happen to the cardiac output? See, what is cardiac output? Cardiac output is how much blood is being pushed in one cardiac cycle, in 1 minute, right? So blood volume is rising. Women has more blood. Heart rate rising. Blood pressure falls. The women blood pressure falls. Women often becomes hypotensive when they are pregnant. So blood pressure falls. Heart rate rise, blood volume rise. As a result, the cardiac output rise. The cardiac work rise. So heart is pushing more blood in every minute. So cardiac workload rise, cardiac output rise. When is it maximum? Cardiac output is maximum in 3rd trimester. At around 34 to 36 weeks, cardiac output is maximum. It rises further when women is labor, is in labor, and cardiac output is maximum immediate postpartum. Immediate postpartum, the cardiac output is extremely high, very high chances of cardiac failure. Now the question can be asked, when the cardiac output comes back to normal? Once the woman is delivered, cardiac output is very high. It goes back to the normal value, it goes back to the pregnancy value, what it was in pregnancy. It goes back to this value after 2 hours. And it goes back to completely normal value which is there in a non-pregnant patient in 2 days. Important question. So cardiac output returned to the pregnant value after 2 hours. Okay, when woman is cool and calm after delivery, it returns to pregnant value after 2 hours. After 2 days, it normalizes to a non-pregnant value. Okay? Right? Good. One diagram is very, very frequently asked. This diagram. When a woman is lying down, she suddenly starts feeling very hypotensive. Why? Why does that happen? We call it supine hypotension syndrome. Very important. I don't even remember how many times it has been asked. Supine hypotension syndrome matlab she's lying supine and she's hypotensive. Why? Who feels hypotensive when lying down? Pregnant woman does, because the large uterus is compressing a very important vessel, IVC. Okay? IVC is being compressed, inferior vena cava is being compressed, and that is why the venous return is hampered, and that is why she feels hypotensive. So what is the reason for supine hypotension syndrome? Compression of IVC. When does it happen? Obviously, when the uterus is heavy enough to compress it. If uterus is small, it can't compress the inferior vena cava. It has to be heavy enough. So it happens after 28 weeks. It only happens in 3rd trimester when the uterus is heavy enough to compress it. Okay? Correct. So it is due to pressure on IVC. Done. Changes in the heart sound, very important. Just the last year the question was asked. What changes happen in heart sound? So we have S1, S2. Okay? So there is exaggerated splitting of S1. S1 is made up of 2 sounds. Mitral valve closes and the tricuspid valve closes. What we call lub-dub. 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 This is heart sound. So what happens in pregnancy is lub-dub becomes split. As such, they are not split. You can't hear them separately. But in pregnancy, they become split. They are split far away. So there is splitting of S1 first. S1 becomes loud. It is normal. It is happening because now heart is getting more blood. That is why. So S1 is now split and it is loud. Also, when the heart is pushing lot of blood, each time heart is pushing lot of blood, like in anemia also, there is a murmur. We call it ejection systolic murmur. Ejection systolic matlab when the heart is ejecting the blood out and blood is so much that it is causing a murmur. So it is ejection systolic murmur. These are the normal changes in pregnancy. These changes are normally seen in pregnancy. Okay? You all are with me? What happened? S1 is split, S1 is loud, and there is an ejection systolic murmur. Okay? One more continuous murmur is heard in parasternal area. Continuous murmur. Like this. It is mammary shuffle. Mammary shuffle is the blood flow is increased towards the mammary glands. Breast is also developing. No, they have to lactate. So blood flow to the breast increase. That continuous murmur because of increased blood flow to the breast is mammary shuffle. Like that the sound is there. Okay? What is abnormal? These are the normal changes. If you find these, perfectly normal. What is not normal in pregnancy? What is not normal is hearing S4. Yes, you can hear S3. S3 is heard. S3 is normally not auscultated. You can't hear it. But in pregnancy, you can hear S3. S3 is ventricular gallop. When ventricle is open, you are feeling a gallop-like sound when it is filling. So that is heard in pregnancy. Ventricular gallop. What is abnormal in pregnancy? S4. Hearing S4 is abnormal. Second, what is abnormal? Diastolic murmur. Diastolic murmur is not normal. Ejection systolic murmur is normal. But if you are hearing a diastolic murmur, it is a pathology. They are not normal. Okay. Question. What is abnormal heart sound in pregnancy? Soft systolic murmur? Milti hai. S3, you can hear it. Loud S1? Yes, S1 is loud, but diastolic murmur is not normal. Okay, it's not a normal sign in pregnancy. Okay? Okay, let's move. A pregnant woman experiences fainting while lying down but feels better in sitting up. We have done that. IVC compression. Okay, now let's see the changes in kidney also. Before finishing what all changes happen in various systems, let's see the renal changes also. It is very easy. Blood vessel is dilated. There is more amount of blood and the blood vessels are dilated. They are dilated so that a lot of blood can be sent to the baby. Okay, so blood vessels are dilated. Now, can you see the kidney? The blood is coming to the kidney. What will happen to the glomerular filtration rate and the renal plasma flow? When the blood is more, obviously kidney will also receive more blood. Renal plasma flow increase. When kidney is receiving more blood, obviously it will filter more blood. Glomerular filtration rate will rise. So blood flow to the kidney rise. The blood that it is filtered. If you are pouring more water into that, chalni, into that strainer, it will filter more. So glomerular filtration rate will rise. Okay? But also due to certain changes, kidney starts secreting protein. So proteinuria is normal in pregnancy. Proteinuria can be seen in pregnancy. Similarly, glycosuria also start happening in pregnancy. So kidneys start secreting protein and glucose. Now because of more blood, the kidney values, serum creatinine and serum urea, they fall. So renal plasma flow and filtration rate rise and the kidney values, the serum values, they fall. Okay? Serum uric acid, more excreted, hence it also falls. Okay? So if you relate everything to the physiology ki bhai, what is happening to GFR? More blood is going to kidney, blood vessels are dilated, GFR will rise. Okay? Since there is more blood, concentration of creatinine will fall. Okay? So you don't need to rectify. Which of the following statement is correct? Does the GFR decrease in pregnancy? No. Okay? Decrease in plasma volume? Let's see which are absolutely incorrect. Plasma volume decrease? No. Blood volume, plasma volume, sub rise in pregnancy. Women has more blood in her body. Now, does the serum creatinine value decrease? Yes. Decrease plasma protein? I told you that yes, protein concentration also fall. Now, what is the right answer? I told you, see, always choose the best right answer. You can have two options which seem correct. Ye dono I am feeling they are correct. But which one is most correct? Which one is more correct? This one. Decrease plasma protein, not the concentration. They have not written the concentration. The total amount of protein. The total amount of protein actually rise. Baby is protein, placenta is protein, everything is protein. So total protein rise, but the concentration fall. So more appropriate answer is this. That the creatinine is falling. Okay? Okay, so always mark what is the best correct answer. Changes in respiratory system. Now, khud socho. Close your eyes, just imagine diaphragm is elevated. When the diaphragm is elevated, there is always some air which is there in the lungs, which is always reserved in the lungs. But when the diaphragm is elevated, what will happen to the residual volume? The residual volume is falling. The diaphragm has risen up, so the air that was reserved in lung, that will fall. So residual volume fall. Similarly, if the residual volume fall, the expiratory reserve volume also fall. ठीक है? Total lung capacity, either it stays normal. Some people say it stays normal because the rib cage expands horizontally. So some stays it normal, but it can also fall. What increase? If you have seen a pregnant woman breathing, they take deep breaths. So tidal volume rise. है ना? Because they breathe, take deep breaths because of progesterone hormones. ठीक है? So tidal volume is something which is rising. Inspiratory reserve volume is rising. So inspiratory capacity is rising. ठीक है? Tidal volume is rising. What is staying normal? Respiratory rate. Pregnant women don't respirate fast. If you have seen them, they don't. ऐसे नहीं, they are not a dyspneic. So respiratory rate is normal. But yes, they are taking deep breaths. So tidal volume is increased. Tidal volume is how much you are taking, inspiring in 1 minute. ठीक है? Minute ventilation rise. But respiratory rate normal. Your vital capacity normal. So vital capacity normal, respiratory rate normal. What falls? That residual volume, expiratory reserve volume, all that falls. ठीक है? Clear everyone? So these are the changes that happen. So because they have asked the changes in heart, they have asked the changes in kidney, they might now this time ask the changes in respiratory system. ठीक है? Now, next we have finished the systemic and basic changes that happen during pregnancy. Now coming to the basic obstetrics, we'll do question by question. Which hormone regulate folliculogenesis? मतलब क्या है? फॉलिकल बनना, फॉलिकल जेनेसिस, फॉर्मेशन ऑफ फॉलिकल, formation of ovarian follicle every month. Who will regulate? Name signifies follicle stimulating hormone. इसका नाम है, it is stimulating the follicle. So which follicle will grow and rupture into Graafian follicle? Who will decide? Follicle stimulating hormone, FSH. Which hormone responsible for ovulation? ठीक है, for folliculogenesis, FSH. Which hormone responsible for ovulation? LH. Basically the LH surge. Why LH surge happen? Which hormone responsible for LH surge? Estrogen. When estradiol is high, it results in LH surge. So estradiol responsible for LH surge responsible for ovulation, for folliculogenesis, FSH. ठीक है? Good. Okay? Who is being sleepy, bhai? I am speaking so loud so that you don't sleep. Have a tea like me. Oh, mine is finished. ठीक है? Okay? Now next, in what stages of oogenesis does the completion of meiosis 2 happen? I hope you know remember the stages of oogenesis. We are going question by question. We have to finish all the questions in 2 hours of obstetrics. We have to bring maximum, yes, good. We have to do maximum what we can in these 2 hours. Okay? We can't just waste any time. So in what stage of oogenesis does completion of meiosis 2 happen? What we have initially is the primary oocyte. है ना? हमारे पास क्या होता है? Primary oocyte, which forms secondary oocyte. Secondary oocyte forms when the meiosis 1 is completed. After secondary oocyte, what forms is a female pronucleus, which is ready for fertilization. Female pronucleus forms when the meiosis 2 is completed. When is meiosis 1 completed? When is meiosis 1 completed? Just before ovulation. So just before ovulation, meiosis 2 is completed. And what does a woman ovulate? When she ovulates, she has secondary oocyte. When is meiosis 2 completed? Just before fertilization. When fertilization is about to happen, then only meiosis 2 is completed. During fertilization. ठीक है? So remember these 2 phases, when the meiosis 1 is completed and when the meiosis 2 is completed. Just before ovulation, just before matlab, if I have to be more specific, 3 hours prior to ovulation. And this is just before fertilization. Okay. Now, when the placenta forms, the question is which part of placenta is attached to the maternal body? See, placenta is formed up of 2 parts. Placenta gets its contribution from mother and placenta gets its contribution from fetus. Both of them contribute and form placenta. The maternal part is called as decidua and the fetal part is called as chorion. Now decidua is basically that endometrium that grows into placenta. Okay? But exactly which part of decidua forms placenta? It is decidua basalis. Okay? Decidua basalis. This is decidua basalis. Number 3. The one lying at the base. This one is decidua basalis, which is just corresponding to this purple layer. This purple layer is chorion. So decidua basalis and chorion, they together form the placenta. What about other decidua? Can you see this decidua, which I am circling, number 2? It is covering the baby like a capsule. Decidua capsularis. Covering the baby like capsule. Is it forming placenta? No. We can clearly see it is not forming. The one standing like a wall, this one standing like a wall, decidua parietalis. Parietalis का मतलब होता है, parietalis का मतलब is wall. So one standing like a wall, decidua parietalis. Is this part forming the placenta? No. What we can clearly see is this part forming the placenta, decidua basalis. Okay? So which part forms the placenta? Decidua basalis. Now, if you see the placenta, it has two parts, obviously. Formed by two, no. So, one is maternal, one is fetal. Which part is what? Can you see this part? The part where the cord is attached. The purpose of cord is all the nutrition will travel through this cord. The fetal vessels are lying in this cord. So, when the cord is attached here, obviously, it is the fetal site. The maternal side doesn't have a cord. It has cotyledons, multiple cotyledons. It's the dirty looking site with no cord. That is maternal site. This shiny layer with cord is fetal site. Okay? Okay? Good. Next question related to again placenta is about the liquor. Oligohydramnios is associated with which of the following? Let's quickly see what is oligo and polyhydramnios. Oligo matlab less amniotic fluid. If I go by definition, what is oligohydramnios? Amniotic fluid index less than 5 centimeter. It is measured in centimeters. या फिर single deepest pocket less than 2 centimeter. Polyhydramnios is AFI more than 25 centimeter. या फिर single deepest pocket more than 8 centimeter. This is the definition. Causes. अगर हमें पता है, if we know how the liquor is formed, how the correct, very good, how the fluid is formed, we will know the cause. How the fluid is formed? From fetal kidney. What is the source of amniotic fluid? Fetal kidney. So everything related to kidney. Renal agenesis. Kidney बनी ही नहीं है या फिर kidney बनी है, the urine is not coming out. Posterior urethral valve. Bladder outlet obstruction. If the baby is not passing out urine, how the fluid will form? Second, suppose kidney is functioning fine, baby is not getting good food, है ना, बेबी को फूड ही नहीं मिल रहा है, बेबी इज नॉट गेटिंग फूड एंड वाटर, हाउ विल बेबी पास यूरिन? सो प्लेसेंटल इनसफिशिएंसी, प्लेसेंटल इनसफिशिएंसी, बेबी इज नॉट गेटिंग फूड, हाउ विल बेबी पास यूरिन? ठीक है. पॉलीहाइड्रमनियोस, all the fluid, how, where it does it goes? Baby swallows it. So if the baby is not able to swallow it, the fluid will increase. Why the baby is not swallowing it? There is a fistula, tracheoesophageal fistula. There is esophageal atresia. Baby is not able to swallow anything, fluid is increasing. Or baby is producing more urine. Just like diabetic people. Diabetic लोग क्या करते हैं? They have polyuria, polydipsia, na? Same, if the baby has high blood sugar, baby will produce more urine. So diabetic mother. In diabetic mother, baby produce more urine. So the answer is renal agenesis. Okay? ठीक है? You all of you already knew. Diagnosis of pregnancy. Now coming to diagnosis of pregnancy, how can you diagnose pregnancy? Based on the blood test. ठीक है? The urine kit, the kit through which you see the pregnancy, the blood test, ultrasonography and certain signs and symptoms. Just see what are the presumptive sign, probable sign and positive sign. Just see them. Presumptive matlab patient is presuming I am pregnant. It is all the signs patient is feeling. what all patient can feel is presumptive sign. So presumptive sign is patient is having amenorrhea. This is something patient is feeling, na? Presumptive sign. Nausea, vomiting, increased urinary frequency, certain breast changes. She is feeling quickening, fetal movement, and urine pregnancy test. Urine pregnancy test done by patient where you see what? Which hormone is tested? HCG is tested. And when you do that kit test, the hormone which is tested is SCG. So everything which is felt and done by patient is presumptive test. Probable test is there is a probability she is pregnant. So all the tests seen by the doctor, all the tests which you can feel and you can see is probable test. Ballotment. You will ballot the baby. Baby is ballottable. All the pelvic signs that we will just discuss, Chadwick sign, Jackmere sign, they all are probable signs. Braxton Hicks contraction. And blood pregnancy test. You will do blood pregnancy test as a doctor. So blood pregnancy test is probable, whereas urine pregnancy test is presumptive. So everything patient is feeling is presumptive. Everything you are feeling and doing is probable. Confirmatory tests are only 3. Remember, only 3 tests are confirmatory of the baby being there in the uterus. First, you can always remember, feel, listen and see. Use all 3 senses. Feel. If you can feel the fetal movement and fetal body parts. You can feel the fetal body parts. That is first sign. You can listen to the fetal heart. Second sign. You can see the fetus on ultrasound. So what are the 3 signs? I can feel the baby part. I can auscultate the fetal heart. I can see it on ultrasound. These are the 3 confirmatory signs. So presumptive, probable, confirmatory. Now you can remember them. I'm just trying to tell you how you can remember them. If question is asked which is presumptive sign, which is probable, you should be able to answer. Right? Okay? I'm not repeating anything because we don't have time. We have to finish a lot. So home-based pregnancy test is based on home-based, that kit is based on which hormone? Correct. It is based on beta HCG hormone. Okay? We check for beta HCG. Now certain named sign of pregnancy, there are certain changes that happen in pelvis in pregnancy. Since you can see the pelvic signs, patient can't see, na? So these are the probable signs. These are not presumptive signs. These are the probable signs. So there are 6 pelvic changes. 3 changes in the cervix, 3 in the uterus. First, the cervix becomes bluish. Not only cervix, the cervix and vulva. The cervix and vulva becomes bluish. This is Chadwick sign. The bluish discoloration of the cervix and vulva is Chadwick sign. Then, the cervix becomes very soft. Very soft. Goodell sign. It is the first pelvic sign that appears. It is the first pelvic sign, Goodell sign. It becomes very soft. Okay? Then third cervix related sign is if you are putting your finger near the cervical os. This is the cervical os. This is the cervical os. If you are putting your finger near the os, it means in the fornix. If you are putting the finger near fornix, you can feel the pulsation of uterine artery. Osiander sign. Os se yaad rakhna. If I am putting my finger near the os, matlab in the fornix, I am putting my finger in the fornix, I can feel the uterine artery pulsation. Osiander sign. So Chadwick sign, Goodell sign and Osiander sign. Okay. Now 3 changes happen, correct. 3 changes happen in the uterus. Uterus becomes very soft. So if I am trying to do a bimanual examination, one finger going through the vagina, one finger coming through the abdomen, they are approximating in between. I can't approximate them in upper segment because of baby being there. I can't approximate in the lower segment because of cervix, but in middle, my fingers will approximate. Just like the letter H. Imagine these are my 2 hands, approximating in between. Hagar sign. So whenever you see H, remember it is approximation in middle. Another similar sign is this one. It is again a bimanual examination, but my fingers are not trying to approximate. My fingers are trying to cup something, trying to hold something in my palm. I'm trying to hold something in my palm. I can feel the contractions. Palmer sign. Palmer sign is when I'm trying to do a bimanual examination and hold the uterus. I'm not doing this. I'm just holding the uterus. Then I can feel the contractions. It is Palmer sign. Okay? Last, lateral uterine enlargement because of the lateral implantation of pregnancy. So lateral uterine enlargement starts happening. It is Piscapli sign. Okay? So these are the 6 pelvic signs seen in pregnancy. Correct? Ultrasound, yes. One of the diagnostic tests. है ना? Remember, seal, feel and listen. So one of the diagnostic sign of pregnancy. Ultrasound में first sign of baby which is seen on ultrasound. First sign which is seen is you can see a G-sac. It is not the confirmatory sign, but it is the first sign seen at 5 weeks. The confirmatory sign of intrauterine pregnancy. Pregnancy is in the uterus. The confirmatory sign is when you see a yolk sac, which is seen at 5.5 weeks. So seeing a yolk sac is the confirmatory sign of an intrauterine pregnancy. The first sign is G-sac. Okay? After seeing the yolk sac, you can see the embryonic pole. That is seen at 6 weeks. So embryonic pole is seen at 6 weeks. And once the embryo is seen, fetal heart is heard when the embryo is at least 7 mm. When embryo is 7 mm, at 6 to 7 weeks, you can listen the fetal heart. You can see the fetal heart. So this is the first sign. This is the first confirmatory sign. Okay? Right? Good. You are preparing well, guys. You are answering good. What is this sign? The bluish discoloration of cervix and vulva also. This is the Chadwick sign or Jackmere sign. Okay? What is this sign? Don't remember a mnemonic for everything. Try to remember using some other methods also. Okay? My hands are approximating just like letter H. Oh, it might be Hagar sign. Right? Earliest sign of pregnancy is earliest G-sac. Okay? We have finished the diagnosis of pregnancy. Now we come to the antenatal care. Quickly we'll do. Good job. Number 1, timing of ANC visits. So there are 2 different guidelines. Our guidelines are very liberal. They say minimum number of antenatal visits. कि भाई इतनी तो करना ही करना है कम से कम. Minimum are 4. Because we know in India 4 भी नहीं करते लोग. So at least minimum number of antenatal visits according to our Ministry of Health and Family Welfare is 4 visits. According to WHO, the minimum visits is 8. So important. When you are asked about the number of minimum visits which is needed in antenatal care, 4 according to Ministry of Health and Family Welfare and 8 according to WHO. Ideally कितना होना चाहिए कम से कम visits? Ideal visits are 12 to 14. ठीक है? So ideal visits are 12 to 14. Remember the minimum also. Do you know how to calculate expected date of delivery? All of you using Neagle's rule? You know all of that, na? LMP plus 9 months plus 7 days. One catch I want to tell you, in case, so this formula is fitting if the women's menstrual cycle is of 28 days. We assume it is 28 days. In case it is not mentioned, we assume it is 28 days. But if question gives you, a woman has a menstrual cycle of 32 days, calculate her EDD. So if the menstrual cycle length is given, it means they want you to understand कि ये formula is for 28 days. What will you do in that case? In case they give you in the question the menstrual cycle length. So how you will change your EDD. Your EDD will be Neagle's formula से जो भी आपकी EDD आएगी, you add the extra days. Extra days are 4. Similarly, if question gives you calculate the EDD of a woman with 26 day cycle. LMP दे दिया उन्होंने और बोला उसकी साइकिल 26 डेज है. सो व्हेन यू कैलकुलेट द EDD माइनस करना है 2 days. It is a correction that has to be done in case the cycle length is given. And if cycle length is not 28 days, you add the extra days in EDD. Okay? Okay? So I know how all of you how to calculate Neagle's formula say whatever. Okay. You want to know the RH incompatibility beta, fetal skull maneuvers and malpresentation. Oh, ठीक है. Okay, I'll try. So EDD पता है सबको ठीक है. Everyone knows gravida para calculation. Always remember gravida matlab how many times she has been pregnant. And currently she has come to you. She is pregnant, tabhi she has come to you. So current pregnancy will be calculated. How many times she has been pregnant? I don't care abortion tha ek topic tha, I don't care, but how many times she has been pregnant? Para hota hai how many times her pregnancy has crossed the 20 weeks. Current pregnancy not included. Current pregnancy include नहीं की जाती है. Abortions include नहीं किए जाते in para. Everything that crossed 20 weeks. अब चाहे 20 weeks के बाद it went into IUD. But if it has crossed the viability, that is counted in para. Gravida means how many times she has been pregnant. ठीक है? Third thing which I want you to tell is twins. If anybody had twins, she was pregnant for the one time, you will call her gravida 1. If she delivered twins, delivery तो एक ही बार हुई ना, तो para 1. So twins are 28 weeks viability इंडिया में है, ठीक है, बट यूनिवर्सली इट इज़ 20 वीक्स. इंडिया में 28 वीक्स क्यों है? क्योंकि वी कांट सेव एनीबडी हु इज़ 24 और 22. तो इंडिया में हमने गाइडलाइन चेंज कर दी है, बट दिस इज़ यूनिवर्सल. व्हेन यू टॉक अबाउट GPLA मीन्स आप यूनिवर्सली क्या फॉर्मूला लगाते हो, तो आप 20 वीक्स लगाओगे उस पर. ठीक है. सो ट्विंस को 1 काउंट करते हैं, पैरा में भी ग्रेविडा में भी. ठीक है, यू काउंट देम 1. Gestational age calculation. What is the best way of calculating gestational age? The best way, crown rump length. In first trimester, using crown rump length is the best way of calculating gestational age. If she comes to you in second trimester, then now you can't use crown rump length. So best way in second trimester is biparietal diameter. इन दोनों में से बेस्ट कौन सा है? This one. So best way to calculate gestational age is CRL. In second trimester it is BPD. ठीक है. Moving ahead. Ideal antenatal visits. Ideal 11, 12, 13 ये था. ठीक है. 12 to 14 is the ideal visits. ठीक है. This is the minimum visit by WHO, minimum visit by our guidelines, Indian guidelines. Which of the following is the best parameter for estimating fetal age by ultrasound in first trimester? Overall also, if it is given which is the best parameter for fetal age estimation, then also it is CRL. Done only in first trimester. Good. Okay? Now, advices during pregnancy. Nutritional intervention. Obviously, healthy diet. How much calorie is needed in pregnancy? In first trimester, 0 kilocalorie. How much in first trimester? 340 kilocalorie. Fifth, 520 kilocalories. So first, second and third trimester, the extra calorie needed is 0 in first trimester. छोटा सा बेबी है, why need extra calorie? 0. Second में 340, उसके बाद increase more. Obviously you need more protein. ठीक है. 1.5 grams per kg of protein is needed in pregnancy per day. ठीक है. Calcium and vitamin D has to be supplemented according to our guidelines. So according to our guidelines, single tablet of calcium and vitamin D, though the question has never been asked, still I'm telling you, 500 milligram of calcium plus 250 international units of vitamin D. This is the single tablet available in government hospital. It has to be taken twice daily. Just like iron, folic acid, calcium, vitamin D tablets are also available. ठीक है. So that has to be taken as 500 milligram calcium and 250 vitamin D. That has to be taken twice daily. ठीक है. Preventive measures. What do we have to give for preventing tetanus? TD. Now according to Indian guidelines, no more TT is given. TD. ठीक है. Tetanus diphtheria has to be given to everybody in pregnancy. There are how many doses? 2 doses. First dose in the first visit, second dose after 4 weeks. One thing, if she has received TD in past 3 years, in last 3 years अगर उसको TD मिला है, then you only give the booster. ठीक है. It is TD, remember TT नहीं मार्क करके आना है. ठीक है. अभी फिलहाल TDAP भी नहीं करना है. TDAP is tetanus diphtheria pertussis. वर्ल्ड वाइड TDAP यूज होने लगा है, बट आर गवर्नमेंट इज स्टिल यूजिंग TD. ठीक है. So TT is almost obsolete. Government has said whatever leftover TT vials are there, finish them and no more TT vials have to be produced. That is what government has said. ठीक है. Iron folic acid tablet has to be taken by everybody. Iron folic acid tablet has to be taken for prophylaxis of anemia from 14 weeks. From 14 weeks of pregnancy, you have to take iron folic acid. ठीक है. And how much is the iron and folic acid in that tablet? 60 milligram elemental iron है और folic acid कितना है? 500 mcg. ठीक है. प्लीज इसको याद कर लो. ठीक है. This has to be taken once daily. 6 plus 6, 600 milligram elemental iron, 60 milligram elemental iron, 500 mcg folic acid. Deworming has to be done of all the women, all the pregnant women in second trimester. सबका करना है by giving a single dose of albendazole. Every woman has to undergo deworming in second trimester. About iron folic acid, this is the prophylactic dose, 500 milligram folic acid. Some women need higher dose of folic acid, जिसे हम कहते हैं therapeutic folic acid. Higher dose, इसका 10 times, 5 milligram. Which women will need therapeutic dose? Those who are obese, those who have malabsorption, those with history of neural tube defect, history of taking drugs which can hamper the absorption like anti-epileptics, डायबिटिक मदर. इनको आपको थेराप्यूटिक डोज देना पड़ता है. थेराप्यूटिक है 5 मिलीग्राम, प्रोफाइलेक्टिक है 500 mcg. प्रोफाइलेक्टिक इज गिवन टू एवरीवन. सो प्लीज रिमेंबर द इंडिकेशंस फॉर एल्बेंडाजोल. बायएनुअली नहीं देना है बेटा. एल्बेंडाजोल हैज टू बी गिवन वंस इन होल प्रेगनेंसी. बायएनुअली जो आप बात करो दैट इज गिवन इन नॉन प्रेग्नेंट एडोलेसेंट. ठीक है. Deworming, yes, deworming has to be done in every woman as a prophylaxis for anemia. जैसे आप आयरन फोलिक एसिड दे रहे हो वैसे ही अनीमिया की प्रोफाइलेक्सिस के लिए आपको deworming करना है. ठीक है. दिस इज रीसेंट अकॉर्डिंग टू द अनीमिया मुक्त भारत प्रोग्राम. ओके, अकॉर्डिंग टू अनीमिया मुक्त भारत प्रोग्राम एवरीबडी विल नीड deworming. ओके, जस्ट अ सेकेंड. अरे मैं आपके आई वॉज ट्राइंग टू रीड द कमेंट्स. कहाँ चले गए? अरे यस यस ओके. ठीक है, हो गया. थेरेपेटिक फोलिक एसिड याद हो गया. बहुत इंपॉर्टेंट है. वेयर डू वी गिव थेरेप्यूटिक डोज. ठीक है. इम्यूनाइजेशन इन प्रेगनेंसी. ऑल दी इम्यूनाइजेशन इन प्रेगनेंसी इज वेरी इजी. All the vaccination can be given. You can't give the live vaccines. So if you are asked which vaccines can't be given, remember live vaccines can't be given. Can I give influenza vaccine? Yes. It's a killed vaccine. Yes. Hepatitis A, B. Pneumococcal दे सकते हैं, meningococcal दे सकते हैं. कौन सी नहीं दे सकते? varicella नहीं दे सकते. It's a live vaccine. MMR is a live vaccine. HPV is not a live vaccine. Still हम HPV नहीं दे सकते because of lack of research. अभी हमारे पास research नहीं है in pregnant women. That is why. Yes, deworming only once for pregnant women in second trimester. ठीक है? Okay, so HPV नहीं दे सकते. It's not live, but we don't have research, so we can't give HPV. Typhoid की 2 आती हैं. Typhoral, जो typhoid oral देते हैं, that is killed. नहीं, typhoral is live, you can't give it. But typhoid injectable, that is killed, that can be given. Only live vaccine that can be given is yellow fever. Yellow fever is a live vaccine and only vaccine that I can give in pregnancy. What about rabies? रेबीज़ की वैक्सीन प्रेगनेंसी में दे सकते हैं? Yes. क्या ये लाइव वैक्सीन है? नहीं. So if the question is asked only live vaccine that can be given, yellow fever, rabies नहीं, rabies is a killed vaccine. ठीक है, rabies is a killed vaccine, it can be very well given in pregnancy. Vaccine that could cause harm if given in pregnancy, yellow fever देते हैं, rabies देते हैं, influenza देते हैं, varicella will cause harm. I can't give varicella. ठीक है. टाइफॉइड की दो तरह की वैक्सीन आती हैं, ओरल और इंजेक्टेबल. टाइफॉइड ओरल आप नहीं दे सकते हो, दैट इज लाइफ, बट टाइफॉइड इंजेक्टेबल इज किल्ड, वो आप दे सकते हो. ठीक है. ओके, विच आर द फॉलोइंग कंडीशन रिक्वायर्ड थेराप्यूटिक डोज ऑफ फोलिक एसिड? थेराप्यूटिक डोज किस में देंगे? हिस्ट्री ऑफ न्यूरल ट्यूब डिफेक्ट्स. व्हाट इज गिवन टू प्रिवेंट न्यूरल ट्यूब डिफेक्ट्स? वेरी इजी, फोलिक एसिड. Ideal number of antenatal visits 12. पोस्ट टर्म प्रेगनेंसी क्या होता है? टर्म मतलब टर्म प्रेगनेंसी मीन्स व्हेन द बेबी इज डिलीवर्ड इन दिस टाइम बेबी इज मोस्ट हेल्दी. सो टर्म प्रेगनेंसी होता है 37 to 42 वीक्स. ये पूरा रेंज है टर्म प्रेगनेंसी का. इफ इट इज लेसर देन दैट वी कॉल इट प्री टर्म, एंड इफ इट इज मोर देन दैट वी कॉल इट पोस्ट टर्म. So post term is 42 के beyond. Term मतलब that when you deliver the baby in this duration, baby is most healthy. इसके बाद डिलीवर करोगे baby will not be that healthy. So post term मतलब होता है beyond 42 weeks, not 40 weeks. ठीक है. A pregnant female in second trimester, she has a 2-year-old child, 2 year का. ठीक है. Which are the following recommended dose of tetanus for pregnant women? ठीक है. टीटी डोज 2, टीटी डोज 3, जैसे आंसर देखा अरे टीटी डोज 2 लगा दिया. टीडी बूस्टर, या फिर आपने टीटी बूस्टर लगा दिया कि अच्छा 2 ईयर का बच्चा है बूस्टर देंगे, टीडी बूस्टर. इफ ऑप्शन इज गिवन ऑलवेज टीडी बूस्टर. ठीक है. टीटी बूस्टर इज नॉट प्रेफरेबल नाउ, राइट? देखा, वही किया ना, टीटी बूस्टर मार्क किया ना, टीडी बूस्टर. फीटल एन्यूप्लॉइडी स्क्रीनिंग. एक सेकेंड. हेलो पापा, 4 बजे से था, वो जा तो पाएगी नहीं आज, रहने दीजिए. था चला गया. तो हाँ, तो जाने दीजिए ना, कोई बात नहीं पापा अभी क्लास में. हाँ ठीक है. चलो, एन्यूप्लॉइडी स्क्रीनिंग. एन्यूप्लॉइडी मतलब क्या होता है? एबनॉर्मल नंबर ऑफ द क्रोमोसोम्स. सो हु डू वी स्क्रीन फॉर एन्यूप्लॉइडी? फर्स्ट ऑफ ऑल, हु डू वी स्क्रीन फॉर एन्यूप्लॉइडी? यूनिवर्सल, सबको स्क्रीन करना है. एवरी प्रेग्नेंट वुमेन इज स्क्रीन फॉर एन्यूप्लॉइडी. इन फर्स्ट ट्राइमेस्टर, व्हाट डू वी यूज इन फर्स्ट ट्राइमेस्टर? फर्स्ट ट्राइमेस्टर में वी डू 2 things. वी डू ब्लड टेस्ट एंड वी डू अल्ट्रासाउंड. बोथ आर डन. सो जो ब्लड टेस्ट है उसको वी कॉल डुअल टेस्ट, क्योंकि वी आर चेकिंग 2 मार्कर्स, इसीलिए वी कॉल इट डुअल टेस्ट. पैप एंड बीटा एससीजी, प्रेगनेंसी एसोसिएटेड प्लाज्मा प्रोटीन एंड बीटा एससीजी इज डन एज अ ब्लड टेस्ट. फॉर अल्ट्रासाउंड व्हाट डू? वी चेक फॉर न्यूकल ट्रांसलूसेंसी. इसको हम कहते हैं लेवल 1 टेस्ट. वी चेक फॉर दिस न्यूकल फोल्ड थिकनेस, न्यूकल ट्रांसलूसेंसी. इफ इट इज मोर देन 3 mm, not good. High nuchal translucency indicate trisomies, Down syndrome, Edwards syndrome, Patau syndrome. ठीक है. It can also be seen in Turner syndrome, and it is also increased when there is a heart defect. ठीक है. So the aneuploidy screening in first trimester is dual marker plus level 1 ultrasound. Both are done. Dual marker के blood test क्या है? PAP and beta HCG. If somebody missed the first trimester screening, then we do the second trimester screening. ठीक है. If she missed the first one, second trimester में now we don't do the nuchal translucency. We can only do the blood test and we call it quadruple test. पहले ट्रिपल करते थे, अब क्वाड्रुपल करते हैं. What is triple test? ABC से याद रखो. Alpha fetoprotein, beta HCG, unconjugated estriol. This is triple test. Add inhibin A. Quadruple test में we add inhibin A, not B, and it becomes quadruple. So in second trimester we only do the blood test. for aneuploidy screening. We can't do the nuchal translucency now. क्या बेटा एन्यूप्लॉयड वुमेन शुड बी गिवन फर्स्ट इंपॉर्टेंस, तो बाकी वुमेन को सेकंड इंपॉर्टेंस दे दो. करना तो सब में है. सो फर्स्ट या सेकंड इंपॉर्टेंस इट डजेंट मैटर, और पहले उनका कर दो बाद में दूसरों का, लेकिन करना सबका है. ठीक है, डोंट गेट इन टू दिस ऑल दिस फर्स्ट इंपॉर्टेंस एज किसको. एवरी वुमेन हैज़ टू बी स्क्रीन फॉर एन्यूप्लॉयडीज, है ना. ठीक है, सारी वुमेन. अब फर्स्ट सेकंड प्रायोरिटी फिट करते रहना बाद में, लेकिन सबको. ठीक है. What is the test in second trimester? Quadruple test. What is the test in first trimester? Dual marker plus ultrasound. ठीक है. Now if any of these, ये तो screening tests है ना, any of these screening tests come positive, what do? You go for diagnostic test. These are not the diagnostic test. So what is the diagnostic test for aneuploidy? अगर फर्स्ट ट्राइमेस्टर में कर रहे हो तो कोरियोनिक विलस सैम्पलिंग. नाउ यू कैन गेट एन इमेज. कैन यू सी अ कैन्युला गोइंग टू द प्लासेंटा. रिमेंबर प्लासेंटा किससे बना था? कोरियन. कोरियन से बना था ना. सो इट इज कोरियोनिक विलस सैम्पलिंग डन एट 11 to 14 वीक्स इन फर्स्ट ट्राइमेस्टर. अगर सेकेंड ट्राइमेस्टर में कर रहे हो देन यू विल डू एमनियोसेंटेसिस. कैन यू सी द नीडल गोइंग इन टू द एमनियोटिक सैक. एमनियोटिक सैक में क्या कर रही है? इट इज टेकिंग द फ्लूइड आउट. सो इट इज एमनियोसेंटेसिस विच इज डन इन सेकेंड ट्राइमेस्टर. These are the diagnostic test. ठीक है. Inhibin A और B मैं बताऊँ कैसे, how I used to remember, very a little stupid way it is, but I used to remember that quadruple में A आ रहा है. Quadruple, that is why I used to remember. That was my way when I was in graduation. Quadruple has A, so quadruple में inhibin A होगा, not B. That is how I used to remember. So these are the diagnostic tests. Another diagnostic test, though not frequently done, is chordocentesis. Chordocentesis इसमें नहीं करते, RH incompatibility में करते हैं. Can you see the needle going into the cord? So that is chordocentesis. It is also done at 15 to 20 weeks. ठीक है? Okay. In which trimester is the quadruple test performed? Quadruple test is performed in the second trimester. ठीक है? So this is about the aneuploidy screening. Quickly going ahead with abortions. Spontaneous abortions, वो abortions जो खुद से हो जाते हैं. Spontaneously the abortion is happening. There are 5 types. First scenario, G-sac is intact and os is closed. Os closed है, G-sac बिल्कुल ठीक है. So it is not abortion, but uterus is threatening you. कॉर्डोसेंटेसिस से बेबी को प्रॉब्लम नहीं होगा. भाई अबॉर्शन हो सकता है ऑब्वियसली, बट इफ़ देर इज़ एन इंडिकेशन यू हैव टू डू द कॉर्डोसेंटेसिस. बेटा करना ही पड़ेगा, है ना. RH इनकम्पैटिबिलिटी में करना पड़ता है. सो थ्रेटेंड अबॉर्शन इज बेबी इज हेल्दी बट इंटरनल ऑस इज क्लोज्ड बट शी इज हैविंग ब्लीडिंग, सो इट इज थ्रेटनिंग यू. थ्रेटेंड अबॉर्शन. इफ द बेबी, कैन यू सी द G-sac इनसाइड इज नॉर्मल. बेबी इज नॉर्मल बट ऑस इज ओपन. इट इज इनएविटेबल. यू कांट प्रिवेंट अबॉर्शन. इनएविटेबल. ऑस ओपन हो गया, अब तो अबॉर्शन होगा. थर्ड कंडीशन, ऑस इज ओपन एंड नाउ नो G-sac, ओनली सम प्रोडक्ट्स आर फेल्ट. इनकम्प्लीट. फोर्थ सिनेरियो, पेशेंट केम टू यू विद ब्लीडिंग, ऑस क्लोज्ड है, जस्ट लाइक फर्स्ट वन. व्हेन यू डिड द अल्ट्रासाउंड, एम्प्टी कैविटी, कंप्लीट. अबॉर्शन हैज गॉट कंप्लीट. एक लास्ट सिनेरियो है. Oh, I'm so sorry. I'll continue in English. I'm sorry. Right? Whatever I've said in Hindi was not related to academics, so you can just skip it. For last scenario, there is no bleeding. Can you see there is no bleeding? Os was closed. He went for the ultrasound, but ultrasound shown you 2 features. There was a big sac, no embryo. Mean sac diameter 25 mm. 25 mm मतलब this big. It's a big sac but no embryo. Or embryo is there, 7 mm embryo is there but no heart. This is the case of missed abortion. So missed abortion has 2 definitions. A big sac of 2.5 centimeter, no embryo. Embryo is there of 7 mm, no heart. That is missed abortion. Okay? So these are the various types of spontaneous abortion. Threatened, okay, first one, inevitable, I can't prevent it, os is open. Incomplete, complete, missed. ठीक है. A patient with early pregnancy with spotting. Which ultrasound finding indicate it is a missed abortion? There is no cardiac activity and CRL is more than 7 mm. What is the other criteria? Your sac is big, more than 25 mm. But there is no embryo. It is an empty sac. This is also a missed abortion. Okay? Okay? Okay. Types of abortion. There are 5 types of spontaneous abortions. Okay, beta. I'm repeating again. First scenario will be given to you. There is bleeding, but os is closed. And when I did the ultrasound, baby was healthy. Fetal heart was present. Fetal heart is present, but yes, bleeding was there. So it is threatening you. Threatened abortion. In case fetal heart was okay, but os was open. If the os is open, I can't prevent this abortion. Inevitable. If os is open and what you felt in PV was certain products, you felt certain products in the vagina, incomplete. Abortion has started happening, it is incomplete. If os is closed, you became happy, maybe it is threatened, but when you did the ultrasound, it was empty. So it is complete. Last scenario is bleeding plus minus, but when you did the ultrasound, there were 2 signs. A big sac, no embryo. Embryo there of 7 mm, but no heart. That is missed abortion. Okay? Okay. Few lines about recurrent pregnancy loss. What are the causes of recurrent pregnancy loss? In the first, recurrent pregnancy loss, matlab 2 or more than 2 abortions. Non-consecutive. It doesn't need to be consecutive. Okay? Suppose there was an abortion followed by a healthy baby, abortion again. It is recurrent. That doesn't need to happen one after the other. So it is 2 or more than 2 abortion. That can be non-consecutive. Now, what are the causes? In the first trimester, the most common cause is the chromosomal aneuploidies. The chromosomal aneuploidies is the most common cause. Then the other causes are mother's autoimmune disorders, APLA. Second trimester में the most important cause is cervical insufficiency. Okay? In second trimester. Other than that, uterine anomalies. These are the more important causes of recurrent pregnancy loss. The question is asked on 2, cervical insufficiency पे और APLA पे. What is APLA? Anti-phospholipid antibody syndrome, diagnosed by modified SAPRO criteria. Okay? The criteria includes 1 clinical and 1 biochemical value. Okay? Clinical matlab either 3 abortions have happened or more than 10 weeks. More than 10 weeks matlab बच्चा बड़ा हो गया. It's a big baby. So more than 10 weeks का 1 abortion. अगर less than 10 weeks के हैं तो 3 abortions. Or a very severe preeclampsia very early in gestation. So either chota baby aborted 3 times, a bigger baby aborted 1 time, or a severe preeclampsia. These are the clinical criteria. Biochemical में either lupus anticoagulant is positive, or anticardiolipin antibodies are positive, or beta-2 glycoprotein positive. Any of these. So if both are present, that is APLA. And the treatment for APLA is, just write down please, aspirin plus heparin, both started as soon as patient is UPT positive. This is the recent guidelines. Whenever I ask the question, people mark when the ultrasound shows pregnancy, when the fetal heart is present. No. Start aspirin, start heparin as soon as patient is UPT positive. That is the recent guidelines for APLA. Okay? Don't write down when fetal heart is coming. If you'll wait for the fetal heart, abortion will happen. So start it as soon as it is UPT positive. Second common cause is cervical insufficiency. Cervical insufficiency is a clinical diagnosis. You will get a scenario of mid-trimester abortion. There is a mid-trimester abortion plus no pain. No pain or mild pain. Or the question will give you a short cervix. Short cervix matlab 2.5 mm. Less than 2.5 mm. 2.5 centimeter. देखते हैं क्वेश्चन में दिया हुआ है. Yes, है ना? Cervix less than 2.5 centimeter. So short cervix, painless dilatation, painless discharge of liquor, all that clinical history indicates cervical insufficiency. What is the treatment for cervical insufficiency? You tie a band which is called as cervical cerclage. That is the treatment. Now there are three types of cervical cerclage. One is given, the highest one. Can you see the highest one, which is given at very high at the cervix, transabdominal. It is given abdominally. The more commonly which is done is the vaginal procedure. The lower one, McDonald cerclage. If I can enlarge it for you. Yes. McDonald one is given at a lower level. Shirorkar is given at a higher level. And at the highest level is transabdominal. These are the three kind of cerclage that is given for cervical insufficiency, which is a clinical diagnosis. Okay? Question. A woman with previous preterm and one mid-trimester abortion has come for cervical length. On ultrasound, cervix is small. Okay? Cervical insufficiency hai. What is this image? Now, see the image. It was a difficult question. Asked last year, I agree, it was a difficult question. So, can you see that the cervical and the uterine, the cervical fold is cut first, and beneath the cervical cut, the suture is applied. Can you see that? The suture is applied once you have cleared the cervico-uterine fold. This is Shirorkar. Shirorkar mein you make a cut in the cervico-uterine ligament, you separate it, and then you apply the suture. That is the Shirorkar. McDonald is very easy. McDonald mein you don't make a cut on cervix. You simply take the needle and tie the suture around the cervix. You don't cut this cervical ligament. So here where this ligament is cut, this is the modified Shirorkar's method. This is modified Shirorkar. In McDonald's, you don't cut the cervical ligament. You just apply the suture. It is the easiest one. 25-year-old, 18 weeks gestation come with draining PV. 18 hafte pe. On examination, membranes have ruptured. Transvaginal scan shows a short cervix. What is it? Short cervix hai, leaking ho gayi hai at 18 weeks. Cervical incompetence. Straightforward hai? ठीक है? It is straightforward. One advice I want to give you here is when something seems very straightforward, तो never use your extra acumen. कि अरे यार इतना straightforward कैसे हो सकता है? कुछ तो है which I am missing. I think it is traumatic injury. I think don't do all that. I have seen many times students trying to just think कि नहीं, question cannot be that straightforward. Questions 90% are very straightforward. 10% tricky होते हैं. ठीक है, 90% are straightforward. So if you think the answer is very much in front of you, mark it. Never overthink, because when you overthink, you always end up marking a wrong answer. Always. ठीक है? Now, induced abortion, very important. Abortion care guidelines. ये है induced abortion. When the woman willingly gets the abortion. वो था spontaneous. So when a woman wants to willingly get the abortion, she has to be under certain guidelines. You just can't go and abort. ठीक है? So let's see. Till what gestational age you are allowed for abortion? Remember, Indian guidelines are very liberal. So there are various gestations at which abortion is allowed. Up to 20 weeks, anyone can terminate pregnancy. Anyone, matlab there are a lot of conditions. If you are a rape victim, if you are physically not fit, if you are mentally not fit. But one condition gives everyone a right for abortion. Contraception failure. Contraception failure के अंदर everyone can say it was a contraception failure and you can get abortion. 20 weeks पे. And you need permission of one RMP. ठीक है? So at 20 weeks, anyone can get abortion under the cover of contraceptive failure. Now there is second category. 20 to 24 weeks wale. Now 20 to 24 weeks is a special category where only few women can get abortion. She is a minor girl. I told you our abortion guidelines are very liberal. Okay? She is a minor girl. She is a rape victim. She is mentally ill, physically not fit, some fetal malformation. All that is allowed. What is not allowed is contraceptive failure. In this category, contraceptive failure women don't come. Law says if you have conceived because of contraception failure, come before 20 weeks. Why come so late? Okay? So contraceptive failure are allowed till 20 weeks. After 20 weeks, you are not allowed. Only these special categories are allowed. Okay? Now there is a third category who is allowed for abortion at any gestation, and that is a significant fetal malformation. If there is a significant fetal malformation, everyone can get abortion, but you need permission of a medical board. Here you need permission of 2 RMP. Okay? Right? So one category is 20 weeks, one category is 20 to 24 weeks, one category is till term. But you need permission of medical board. So many questions have been asked on this CAC guideline. Okay? Comprehensive Abortion Care Guideline. Important things which is written inside the guideline, which I thought is important for you, is consent. If the woman is more than 18 years, only her consent is needed. Consent of partner is not needed. But if she is less than 18 or she is mentally ill, she is minor or she is mentally ill, whose consent is taken? Guardian. Guardian can be anybody. It can be the doctor, it can be the partner, it can be the parent, it can be the nurse taking care of her, anybody. So who will give consent? It is the guardian. Don't write down parent or partner. We don't know who's the guardian. Okay? Now the methods of abortion. Okay? This is done. Methods of abortion. Now first trimester, second trimester may we use different methods. Medical method for abortion, the easiest one, can be used up till 9 weeks. So up till 9 weeks you can use the medical method of abortion. Okay? What is the medical method? WHO में 3 methods है, हमारी guidelines में there is 1 method. So remember this one: mifepristone and misoprostol. Simple. A packet comes where there is mifepristone also, misoprostol also. You give it and abortion will happen. It is done only if the gestation is less than 9 weeks. Yes, legal guardian. Guardian or legal guardian? Legal guardian is a more appropriate word. Guardian is also a word, right? So legal guardian sounds more appropriate, correct. How to take mifi and miso? Mifepristone dose 200 milligram. Do you have to remember the dose? Yes, of course. Mifepristone 200 milligram given on day 1. Day 2 पे nothing done. Day 3 पे misoprostol given 800 mcg. मिफी 200 देते हैं, मीजो 800 mcg देते हैं, बस. This is the only method given by our guideline for medical abortion in everyone who is less than 9 weeks. कितने gestation पे? Less than 9 weeks. After 9 weeks, surgical abortion. And surgical method is vacuum aspiration. You just take the vacuum, either this manual syringe is taken or you connect the cannula with the electric pump. You don't need anything else. You just create a vacuum and suck it out. So in first trimester, only vacuum aspiration is done. No curate. You don't need curate. You need manual or electric vacuum aspiration. If it is less than 9 weeks, medical abortion. Second trimester. पहली बात तो second trimester में medical abortion is not done. According to our guidelines, only surgical is done. And now the surgical method is dilation and evacuation. It is not vacuum aspiration. You can't just remove a big pregnancy with vacuum only. What you need is dilate and evacuate. Evacuate मतलब होता है empty करना. So the term is, remember, the focus on the term. The question will be asked on those terms. Dilate and evacuate. Evacuate using this ovum forceps and the suction, both. So both of these are used after 12 weeks. And the term is dilation and evacuation. The term for first trimester is vacuum aspiration. ठीक है? ठीक है? Vacuum aspiration and dilation and evacuation. Terms, please, you have to be very clear with that. These are the Indian guidelines, so there should be no confusion about that. MTP for contraceptive failure can be done up to how many weeks? A woman requests for MTP, doctor decide to perform suction evacuation. देखो, suction evacuation. Till what gestation आप suction कर सकते हो? Suction. It is not dilation and evacuation. It is suction. आप 12 weeks तक only suction कर सकते हो. ठीक है? Evacuation only using suction. What is the appropriate step according to MTP Act for a married lady with failed contraception at 26? Failed contraception के साथ she is coming so late. Is she allowed? If no fetal anomaly, continue. She will have to continue. She is coming so late. She is not allowed. है ना? A woman presented in her 8th week for MTP. What is the dose of misoprostol? I told you, remember the dose. What is the dose of misoprostol? 800 mcg. What is the dose of mifepristone? 200 milligram. ठीक है? Which of the following is required for MTP at 21 weeks of a fetus diagnosed with meningomyelocele? Meningomyelocele है उसको at 21 weeks. What permission is needed? Opinion of one doctor? No. 2 doctor? Yes. जैसे ही आप ये आंसर देखते हो, you mark it. नीचे आओ. हर consent and opinion of 2 doctors. उसकी भी तो consent चाहिए. So please, this is a very big example that read all the options. Even if answer is in front of you, read. हर consent with opinion of 2 doctors is more appropriate. ये incorrect नहीं है, but ये ज़्यादा correct. This is more correct. So read all the options. Yes, right? You remember meso-mifi dose? Yes. So remember the doses. ना जो भी Indian guidelines है, and which is very basic. Abortion is something you will find. Once you will clear the exam, you will be posted somewhere. You will find abortion patients. So you're expected to know the dosage of iron folic acid, dosage of oxytocin to be given for PPH, dosage of MTP. ये dosages आपको पता होने चाहिए. ठीक है? Now finish ectopic pregnancy now. What is ectopic pregnancy? Pregnancy implanted outside uterus. 95% of time it is implanted in the tubes. ठीक है? How do you diagnose? Diagnosis is based on symptoms first. Symptoms are very typical. Amenorrhea मिलेगा, pain and spotting. So pain, it's a triad of pain, spotting and early pregnancy. Pain, amenorrhea and vaginal spotting. But the diagnostic method is ultrasound. What do you see on ultrasound? You see on ultrasound adnexal mass. Uterus is empty and you see mass in the adnexa. And this mass sometimes has a good blood supply which looks like a ring of fire. ठीक है? Ring of fire is sign of ectopic pregnancy. So you see empty uterus, adnexal mass, diagnostic ultrasound. ठीक है? Cervical motion tenderness is also there, and when there is rupture, there are signs of peritonitis. ठीक है? Now, this what is the one characteristic feature seen in ectopic pregnancy? Thin endometrium with no mass, empty uterus with adnexal mass, and fluid. Why fluid comes? Sometimes because of rupture, the fluid comes in pouch of Douglas. ठीक है? Which of the following is most common location of implantation in ectopic? Most common location is tubes, and in tubes the most common location is ampulla, where the fertilization happen. जहाँ fertilization हुआ वहीं पे it has stopped, it has implanted. It is the most common site. ठीक है? Fertilization, so A. Okay. A 27-year-old female presents to emergency with bleeding per vaginum. Amenorrhea is very early amenorrhea. She is in shock with positive beta HCG. Remember, UPT positive plus shock is always ectopic unless you diagnose otherwise. So whenever a UPT positive patient comes with shock, the first diagnosis is ectopic, followed by once you investigate. Okay? So on examination, mass is palpable. What is the most likely diagnosis right now? The most likely is ruptured ectopic. Okay? How to manage ectopic? Now ectopic can be managed in 3 ways. Expectant, कुछ मत करो, don't do anything. Medical and surgical. Expectant में what do we do? Expectant में if she is stable, if the sac is small, small मतलब less than 3.5 and beta HCG is also less than 1500, then you just follow her up. How do you follow? You follow by titrating the beta HCG again and again. It will fall. Small sac, stable patient, less amount of beta HCG and cardiac activity absent. Very important. कार्डियक एक्टिविटी शुड बी एब्सेंट. मेडिकल में बीटा एसीजी थोड़ा ज़्यादा है, 1500 to 5000. सैक इज स्मॉल, लेस देन 3.5, कार्डियक एक्टिविटी एब्सेंट. रिमेंबर, अगर इफ कार्डियक एक्टिविटी इज देयर, दिस सैक विल ग्रो. It will definitely grow, it will rupture. So cardiac activity should be absent. What do you give in medical management? Single dose of methotrexate IM. Single dose. Multi-dose is given also, but in very less cases. 90% cases में single dose is sufficient. Surgical. If the sac is big, more than 3.5, beta ECG is more than 5000, cardiac activity is present, patient is not stable, surgical. And the treatment is laparoscopic salpingectomy. You remove the tube. ठीक है? You remove the tube. No, sex size is 3.5. Okay, 4, 3.5 very close by, but yes, the exact size is 3.5. ठीक है? Yes. The sac means that gestational sac seen in the adnexa. The G sac they are talking about. Which of the following is not an indication for expectant management in unruptured ectopic? Not an indication for expectant means you will not do expectant. Beta ECG less than 200, very less, I'll do expectant. Asymptomatic, yes. Decreasing HCG, very good thing. But sac size is more than 4. Oh, big sac size. I can't do expectant. So this is our answer. ठीक है? Okay. Stable में, if it is stable, you can either give the conservative or you can give medical. In suspected ectopic, which hormone is measured? Whether it is resolving, not resolving, beta ECG. Not progesterone, beta ECG is measured. ठीक है? Gestational trophoblastic disease. Gestational trophoblastic disease is abnormal. We don't have much time left, no? We are just dealing with abortions. Let's finish this fast. Gestational trophoblastic disease. Molar pregnancy, Molar pregnancy is one of the gestational trophoblastic disease. Abnormal trophoblastic proliferation. Okay, mole can be of two types, complete and incomplete. Complete and partial. Okay? This is the complete mole. When there is no fetus, absolutely no fetus. It happens when an empty ovum is fertilized by 2 sperms. So है तो diploid, but it is completely androgenic. All the chromosomes are paternal. Whereas partial mole has a fetus. Why? Because the ovum was not empty, but by chance fertilized by 2 sperms. Instead of 1 sperm, 2 sperms came. So now it is triploid. Does it has maternal constituents also? Yes. But it is triploid, it ends up in being partial mole. ठीक है? It is not normal. How patient present? Patient present with pregnancy and bleeding and hyperemesis. Why hyperemesis? Because HCG is very high, very high. ठीक है? How do you diagnose? The confirmatory diagnosis is by histopathology. Though ultrasound shows you snowstorm appearance and theca lutein cyst. So question gives you snowstorm appearance and theca lutein cyst, that is the molar pregnancy. ठीक है? We'll stretch this session a little. हाँ, अगर हम नहीं complete करेंगे, we'll stretch it a little. I hope if there is no other class, we'll stretch it a little. So snowstorm appearance and theca lutein cyst. ठीक है? Diagnosis is ultrasound that show these signs, but confirmation is histopathology. ठीक है? Now question आया था 2023 में, 28-year-old woman at 10 weeks gestation show a snowstorm appearance. ठीक है? You got to know it is molar. Her beta ECG is elevated. Obviously, what is the management? So what is the management of molar? Please never write molar का management methotrexate. Molar में management is take out everything, suction and evacuation. Just evacuate everything, that is the treatment for molar. ठीक है? Not methotrexate. And once it is done, you monitor it using beta ECG. It is pre-malignant condition. It can turn into invasive cancer. So you monitor it using beta ECG. ठीक है? Till 6 months. Till 6 months you monitor beta ECG to see whether it is turning into cancer or not. So your answer will be dilation and curettage. Not methotrexate. Methotrexate molar में नहीं देते. मेथोट्रेक्सेट देते हैं या तो एक्टोपिक में, और मेथोट्रेक्सेट इज गिवन इन केस ऑफ इन्वेजिव कोरियोकार्सिनोमा व्हेन इट टर्न्स इनटू कैंसर. ठीक है. Now this is again a very difficult question of last year. I don't know why it was asked. 46XX एक तो डिप्लॉयड है. ठीक है. एंड P57 KIP2 नेगेटिव, विच पैथोलॉजी? देखो P57 KIP2 chromosome marker comes from mother. All of us have this marker and it comes from mother. If it is negative, it is there in everyone. If it is negative, it means maternal genome was absent. Diploid है but maternal genome absent है. What is it? Complete mole. Partial mole में maternal genome is there. So partial mole is KIP2 positive. It is the complete mole which is KIP2 negative. Very difficult question, but now it has been asked, so you should know the answer. ठीक है. Now GTD can convert into something called as GTN, which is gestational trophoblastic neoplasia, which is a cancerous condition. Which GTD will convert into cancer? If it is old age group. Old age group, anything can convert into cancer. Old age group is itself a high risk for cancer. So old age women, I don't know what the hell is this question. So these questions don't decide your rank. If you don't mark these such questions right, it is okay. I advise don't lose your marks. If you don't know the answer, leave them. Don't lose your marks, okay, on these questions. Right. Okay. So old maternal age itself a risk factor. Beta HCG very high. So whenever beta HCG is very high risk, it will turn into cancer. If the beta HCG is high, the uterine size will also be high. If the beta HCG is high, the theca lutein cyst will be big. So big cyst, big uterus, high beta HCG. All of them are the risk factor for converting into GTN, that is the cancer. Okay? What is the management of cancer? Here you give chemotherapy. If it is a low risk patient, okay, there is a prognostic scoring. If we take out the scores, if it is a low risk patient, the treatment is methotrexate. But here multi-dose. Single dose was for ectopic. Here it is a multi-dose methotrexate, which is the treatment for choice. Okay, given at day of 1, 3, 5, 7, and you alternately give folinic acid. Okay? If it's a high risk patient, then you give proper EMACO regime. Okay? EMACO regime is given, which is etoposide, methotrexate, actinomycin D, cyclophosphamide and vincristine. So this multi-dose chemotherapy is given if it's a high-risk patient. In low risk, you give multi-dose. But remember, molar mein, you just do dilation and evacuation. Choriocarcinoma is a cancer, so you always monitor the patient, whether the cancer is gone or not. You monitor again using the hormone HCG. And monitoring is done till 1 year. Since you are monitoring HCG, will you let her for 1 year? So avoid pregnancy for 1 year because we have to monitor your cancer hormone. Okay? Again, questions on that only. A woman who underwent dilation and curettage for molar 6 months ago now has persistent symptom of pain and distension. When you evaluated, beta HCG was high. वो कम नहीं हुआ. It is not reduced, it is high. And cannonball foci on X-ray. Cannonball foci क्या होते हैं? They are malignant cells in the lungs. It indicates malignancy in lungs. So what is it? It is turned into a cancer. Okay. So this finishes our early pregnancy complications. Now we are left with 20 minutes. Let's finish the medical complications. We'll take extra half an hour and we'll finish the labor. Okay. Medical complications in pregnancy. Diabetes. Question 1. For the screening of diabetes, what is the amount of glucose used? 75 gram. Now some questions on screening. Who should be screened? Universal. In our country, it is universal. In US, it is high risk. Only high risk women who are obese, family history, they are screened. But in our country, everyone is screened. Okay? Universal screening for diabetes in our country. Okay? What method do we use? We used DIPSI method. Diabetes of pregnancy study group of India we use. This is the method. हेलो, वो ख़त्म हो गया, जल्दी था आज. ठीक है, ओके. Screening is done twice. ठीक है, how many times do we screen? We screen the women twice. One is done at the first visit. At first visit we screen the women, and second screening is done at 28 weeks. So remember these points. How many, which woman is screened? Everyone. How many times screened? Twice. First visit पे और 28 weeks पे. The method uses DIPSI. How much glucose we use? We use 75 gram glucose. After giving her 75 gram glucose, we measure her blood sugar at after 2 hours. If it is more than 140, she is GDM, gestational diabetes mellitus. So every woman diagnosed to be having high sugar in pregnancy is GDM, irrespective of gestation. If you have diagnosed high sugar at 8 weeks, she is GDM. High sugar diagnosed at 20 weeks, she is GDM. So gestational diabetes mellitus diagnosis doesn't depend on gestation. Any gestation, if you have find out high sugar, she is GDM. Only one thing, GDM में यानी gestational diabetes mellitus में sugars of beta, I have got your doubt बच्चे, you have want RH incompatibility and the maneuvers. I will take that. I have to extend it half an hour more, but I will take the RH incompatibility and malpositions both. Don't worry. I'll complete it, then only I'll go. ठीक है? I'm not ignoring it. So, gestational diabetes mellitus is irrespective of gestation. If she is diagnosed in pregnancy, she is GDM. Only thing, if the sugars are very high. GDM में sugars are never very high. 2 hour post glucose value is more than 140, but we call it OGTT value. If your OGTT value is more than 200, it is very high. If your fasting blood sugar is more than 126, very high. If your HbA1c is more than 6.5, very high. It means you are overt diabetes. Overt diabetes मतलब you are already diabetes. So आप GDM हो, whether you are GDM or whether you are overt, it doesn't depend on gestation. It depends on the sugar values. Question आया है इस पे. So if at 12 weeks your sugar values are below 200, you are GDM. If it is more than 200, you are overt diabetic. ठीक है? देखो, this was the question. 30-year-old primey diagnosed at 18 weeks, plasma glucose level 243, fasting 146 and HbA1c 7.6. See these values, it is high. Fasting so high, HbA1c so high. What is the diagnosis? Is she gestational diabetes? No. Such high sugar, overt. She is overt. Not because of gestation, because of high sugars. ठीक है? Screening method for GDM is done between एक तो first visit पे and another one at 24 to 28 weeks. ठीक है? Right? What fetal complications can happen? Remember, in diabetes and in GDM, the fetal complications are different. Diabetic patient develops the fetal anomalies. ठीक है? Patient can have spontaneous abortions, patient can have malformations, and that happens only in somebody who is overt diabetes. Overt diabetes में sugars are very high. That is why abortion and malformation happen in overt diabetes. The most common malformation in diabetic mother is heart defects. Cardiovascular defect, that too VSD, is the most common. So which is the most common heart defect? What is the most common heart defect that happen in diabetic mother? VSD. The second most common system which is involved in diabetes is neural tube defects. ठीक है? So is it not crystal clear to you, Dr. Panic? Doctor, what's your name is? If you have a doubt, you can always ask बच्चे. We have to go fast because obviously it's a revision. है ना? We can't go into the details. Yes. The most common defect in a diabetic mother is heart. In heart, the most common defect is VSD. The most specific is TGA. Overall, the most specific anomaly, which is rare, not common, rare, but seen only in diabetic mother, is sacral agenesis. Sacral agenesis is a sign which is seen in case of a diabetic mother. Okay? So this is very specific of a diabetic mother. Other things that can happen in a diabetic mother is hydroamnios, preterm intrauterine death. These are very common. But remember the malformations. उससे ज़्यादा remember anomalies are present only in overt, not in GDM. GDM में anomalies don't happen. GDM में baby grow oversize, baby becomes obese, so there are chances of preterm, there are chances of large baby, shoulder dystocia and injury, but malformations don't happen in GDM. ठीक है? Do you got it? Question is asked, which risk is there in GDM? Don't mark malformation. Macrosomic baby happens. Malformation over diabetes में होता है. Why? Sugar values are so high. Sugar values are so high. That is why malformation happen in overt diabetes. Now see the question. Oops, sorry. So if the patient asks me if it's a diabetic woman, she want to ask me what is the risk for malformation. But I am not going to cover the gynecology. I can't cover gynecology. I'll be doing only the obstetrics. Okay? I'm sorry, but I can just cover the obstetrics in this much time. Now, best test to predict malformation. If she asks me, ma'am, what is the malformation risk? HbA1c. Higher is the HbA1c, higher is risk of malformation. So, to predict malformation, HbA1c. What is my target? What is then ideal HbA1c before pregnancy so that she doesn't develop malformation? Ideal HbA1c should be 6.5. Before going for pregnancy, a diabetic mother should have HbA1c less than 6.5. Okay? So what are the targets? Targets are HbA1c less than 6.5, fasting less than 95, 1 RPP or 2 RPP less than these values. This is the target, and then only you should go with pregnancy. Otherwise, you will have a high risk of malformations. Okay? Okay? Gynae sessions, I have to talk to the company. If they'll allow, then only I can take the gynae sessions. Right? It's not in my hands. So remember the targets. It is important. What should be the targets if you are planning pregnancy, if you are diabetic? First of all, malformation risk is there in diabetes or GDM? Over diabetes. What is the best predictor of malformation? HbA1c. Then what should be the target sugar value? These. I'll share the PDF. Everyone, you have to read the PDF before going to sleep, or at least tomorrow. Okay? Delivery of a diabetic mother or a GDM mother, if the sugar is controlled, on insulin, on metformin, if the sugar is controlled, 39 weeks. If the sugars are not controlled, 37 weeks. Okay? पहले था if controlled on diet at this gestation, if controlled on insulin, deliver at this. No. If it is controlled, deliver at 39. If it is not controlled, deliver at 37. Simple. Okay? Now this finishes our diabetes in pregnancy. Now comes the hypertension in pregnancy. Hypertension in pregnancy is different. There are 2-3 types of hypertension: chronic and preeclampsia. Chronic hypertension means she was hypertensive, pehle se she was hypertensive. And one is preeclampsia, pregnancy induced. She is pregnancy induced hypertension, preeclampsia or gestational. It depends on the gestation. If she is diagnosed as having high BP at less than 20 weeks, she is chronic hypertensive. If she has high BP at more than 20 weeks, it is pregnancy induced. In pregnancy induced, hypertension develops only after 20 weeks. It can be preeclampsia, it can be gestational. If urine protein positive, preeclampsia. If urine protein negative, gestational. But gestation is 20 weeks. So hypertension ki definition depends on the gestation. Diabetes ki definition depends on the sugar values. ठीक है? What is preeclampsia? Hypertension after 20 weeks plus any of the following. Either there is proteinuria, or if proteinuria is not there, then also if there is a maternal organ dysfunction, means your LFT is deranged, the patient's KFT is deranged. ठीक है, uteroplacental insufficiency, there is IUGR, there is oligo, then also it falls under the definition of preeclampsia. Hypertension with either protein positive or maternal organ dysfunction or placental insufficiency, it is all preeclampsia after 20 weeks. Definition of significant, I told you kidney में proteinuria happens, remember the physiology? I told you kidney starts secreting protein. It is normal. So it has to be significant proteinuria. Before you call it preeclampsia, it should be significant. Matlab more than 300 milligram. In 24 hours, more than 300 milligram. Or you did the dipstick, more than +1. ठीक है? Hello? हाँ. Class. पूछ लो यार. ठीक है, सो प्रोटीन मोर देन 300 milligram और यूरिन डिपस्टिक +1, राइट, और यूरिन प्रोटीन क्रिएटिन रेशियो मोर देन 0.3. दिस इज सिग्निफिकेंट. ठीक है, चलो अब देखते हैं. यंग प्राइमी ग्रेविडा एट 32 weeks with high BP, urine dipstick 2+. What is the diagnosis? 32 weeks पे BP is high, protein is also positive. What is it? It is preeclampsia. Is it gestational hypertension? No. Is it chronic hypertension? No. ठीक है. 17 weeks with hypertension, BP high है, repeatedly it is again high. What is it? 17 weeks. Now it is chronic hypertension. ठीक है, राइट. सो हाइपरटेंशन डेफिनेशन डिपेंड्स ऑन जेस्टेशन. डायबिटीज का जो क्वेश्चन था दैट वाज डिपेंडिंग ऑन द शुगर वैल्यू, राइट. नाउ प्रीएक्लेम्सिया, व्हेन अ पेशेंट कम्स विद प्रीएक्लेम्सिया, हाउ डू यू मैनेज? फर्स्ट ऑफ आउट, रूल आउट सिवियर फीचर्स. व्हाट इज सिवियर प्रीएक्लेम्सिया? बीपी मोर देन 160/110 फर्स्ट, और अगेन organ dysfunction. So if liver deranged, kidney deranged, cerebral symptoms are present, it is severe. So admit if any severe sign are present. So any severe preeclampsia has to be admitted. When do you deliver? Severe preeclampsia delivered at 34 weeks, whereas non-severe means BP is less than 160/110, no organ dysfunction, no cerebral symptoms, deliver at 37 weeks. Okay? So 34 weeks, 37 weeks. How do you manage? The treatment of BP is done by antihypertensives. Labetalol is the first choice. In a non-severe hypertension, the drug of choice is oral labetalol. Oral. In a severe hypertension, the drug of choice is IV labetalol. But the drug of choice is labetalol. In both of them. Second choice is nifedipine. Third choice is methyl-dopa. In non-severe. ये देखो. In non-severe, 3 drugs are used. Oral labetalol, nifedipine, methyl-dopa. Methyl-dopa is slow acting, so you can use it in non-severe. Remember the contraindications. Labetalol being an alpha and beta blocker, both. I cannot use it in asthma. Very important. Labetalol cannot be used in asthma. I cannot use it in heart disease. It cannot be used in a heart disease patient. क्या लिख रही हूँ मैं? So asthma and heart block are 2 contraindications for labetalol, which is the drug of choice. Certain antihypertensives which are contraindicated in pregnancy. ACE inhibitors, AT antagonist. They cause renal failure in the baby. And sodium nitroprusside. Sodium nitroprusside is the last choice, relatively contraindicated, because it can cause cyanide toxicity. So these are the one which are contraindicated in pregnancy. ACE inhibitors, AT antagonist, and sodium nitroprusside. ठीक है. I primi gravida women at 26 weeks present with BP 150/90. What is the next test? She is at 26 weeks. She is pregnancy induced hypertensive. I don't know whether preeclampsia or gestational hypertension. How will I know? I'll do a urine dipstick. Baki investigations are also done to know whether it is severe or non-severe. But first thing is, let me see it is preeclampsia or not. So I'll do urine dipstick. Good. Good bache. Pregnant female with asthma has hypertension. एक तो hypertension है, pregnant and asthma. What can be used? Can we use ACE inhibitors in a pregnant woman? No. In asthma patient, if you go back, if I told you, remember this, asthma. In asthma patient, can I use labetalol? I can't. Neither oral, neither IV. What can I use? I can use nifedipine. Okay? If I talk about severe hypertension, do I know what is severe hypertension? I know, but management is different. Severe hypertension mein, I don't need just antihypertensive. I need three things. I need to give Maxilf first. Then I give antihypertensive. And then I deliver. Just give me a second. Just give me a second, everyone. I have another class which I have to, I think, postpone because this class might extend. है ना? Okay, so this might extend, so I'll just have to postpone the right. ठीक है. सिवियर हाइपरटेंशन का 3 prong मैनेजमेंट होता है. सबसे पहले मैक्सेल्फ, then antihypertensive and then delivery. ठीक है. So Maxilf has to be given by Pritchard regime. Pritchard, which is the IM regime. Remember this regime, it is very commonly used in our country. The IV regime is Zuspan. ठीक है. The loading dose is 4 gram in both of them. And whenever you give IV, you give in a lesser dilution, 20% dilution. ठीक है. So IV given in 4 gram IV 20%. Pritchard में 4 gram IV देते हैं, 10 gram IM भी देते हैं. इसीलिए we call it IM regime because we give IM also. 10 gram is given IM. Important is maintenance. No. That class is for the postgraduates. That's not for the undergraduates. That's a postgraduate class. I will take gynae. I'll talk to the team and then I'll take gynae. Gynae session will be a small session. So I'll ask them if we can finish it in 1.5 hours. है ना? So loading dose is 4 gram IV plus 10 grams IM. तो कितना loading dose दिया हमने? We have given 14 grams. Important is maintain that level, otherwise she will convulse. She's at risk of eclampsia. She's at risk of convulsion. So I'll maintain the dose by giving IM again and again every 4 hours. How much? 5 gram. So first I give 14 gram loading and then every 4 hour I give 5 gram IM. This is the Pritchard regime. Maxilf is a toxic drug. So when I come every 4 hours for the injection, I check for signs of toxicity. Once the signs are negative, then only I give injection. So I come every 4 hours and give check the signs for toxicity, which are 3. I check for deep tendon reflex, which is the first sign. I check for respiratory rate depression, which is the second sign. And I check for urine output. So I check for deep tendon reflex, I check for respiratory rate, I check for urine output. How frequently? Every 4 hours. When I'm coming for repeat injection, I check it. If there is a toxicity, the antidote is calcium gluconate. ठीक है? Okay. So what is the drug of choice for preventing convulsion? Do we give it in severe preeclampsia? Yes. For preventing convulsion, we give Maxilf. For treating convulsion, we give Maxilf. Loading dose is 14 gram. Maintenance is 5 gram every 4 hours. When I come every 4 hours, I check 3 signs. Deep tendon reflex, I check respiratory rate, and I check urine output. ठीक है. So deep tendon reflex should be normal. It can be exaggerated. Exaggerated हो सकता है. It is exaggerated in. Thank you so much.
मैम मुझे प्रिस्क्रिप्शन चाहिए सर का.
सर आ गए?
नहीं पेशेंट
सर को बता दो.
बता दीजिए. एक नहीं मैम हो जाएगा 2 मिनट.
है. So respiratory deep tendon reflex should be present. Absent is sign of toxicity. So it should be present 16 per minute. ठीक है. And urine output should be more than 100 ml. When you are coming in every 4 hours, it should be more than 100 ml. This is a normal non-toxicity. And what is the antidote? Antidote is calcium gluconate. ठीक है. So first thing in severe preeclampsia, the first thing I gave is Maxilf. The second is antihypertensive. What is the antihypertensive of choice? IV labetalol. But contraindicated in asthma. So second choice is again nifedipine. Nifedipine is always given oral. What is my third choice? I told you methyl dopa is slow acting. In severe hypertension, now my third choice is not methyl dopa. It is hydralazine. Labetalol, nifedipine and hydralazine in severe hypertension. Non-severe में labetalol oral, nifedipine and methyl dopa. And once the patient is stable, deliver her. ठीक है. This is severe hypertension. HELLP syndrome. HELLP syndrome is a form of severe hypertension. Just like eclampsia, it is HELLP syndrome. HELLP syndrome is made up of 3 things. Hemolysis, elevated liver enzyme and low platelet. What will question give me to show hemolysis? Question क्या देगा so that I know it is hemolysis? High LDH. LDH is an RBC enzyme. It is there in liver also, but high LDH indicate hemolysis. Or the question will give me anemia. Or the question will give me hemolyzed RBCs. It indicates hemolysis. Elevated liver enzyme में question will give me AST ALT. So high LDH doesn't indicate liver enzyme. High LDH indicate hemolysis. High AST ALT indicates liver enzyme. And low platelet less than 1 lakh. When all of them are present, all of them, then it is HELLP syndrome. So question will come, a scenario will come and ask you the diagnosis. FMG में they majorly ask about diagnosis. ठीक है. HELLP syndrome में all 3 are present. HELLP में they will give you some sign of hemolysis, some signs of elevated liver enzyme and thrombocytopenia. How do you manage? It is severe hypertension. Same. Maxilf, antihypertensive, deliver. ठीक है. Antihypertensive contraindicated in pregnancy is nifedipine contraindicated. Even if I don't know the answer, one thing I know, nifedipine is given in pregnancy, yes. Labetalol is given, yes. I've seen methyl dopa given. This is contraindicated. Even if I don't know the category, I know other 3 are given. ठीक है. So this finishes our hypertension. Good. ठीक है. Now comes the complicated pregnancies. So complicated pregnancy, you told me to teach you the RH incompatibility.
क्लास करनी है क्या?
Half an hour, please. Half an hour चलेगा.
ठीक है, फिर वहाँ देख लूँगा.
Please.
YouTube क्या लेके बैठे?
YouTube पे चल रही है. So let's discuss the RH incompatibility. See, when we are reading RH incompatibility, what is RH incompatibility? Mother is RH negative. अभी तक मदर के ब्लड में RH एंटीजन वॉज नॉट देयर. इट वॉज एट ऑल नॉट देयर. सडनली शी बिकम्स प्रेग्नेंट विद अ RH पॉजिटिव बेबी. शी हैज़ गॉट अ न्यू एंटीजन. नाउ शी फॉर्म्स एंटीबॉडीज एंड स्टार्ट पासिंग दिस एंटीबॉडी टू द बेबी एंड किलिंग द बेबीज RBC. दिस इज न्यू ना. शी विल फॉर्म एंटीबॉडीज. दिस इज RH incompatibility. So when I read RH incompatibility, there are 2 things. One is prevention. Let's not let these antibodies form. Somehow prevent antibody formation. This is prevention. Another one is treatment. If the antibodies have formed, how can I prevent anemia? How can I prevent baby's anemia? So there are 2 segments. ठीक है. how can I prevent anemia, and how can I prevent formation of antibodies, how can I treat anemia. So first, prevention. Once a woman comes to me with Rh negative pregnancy, I want to see whether she has antibodies or not. So for seeing antibodies in mother, the test is done indirect cum test. ICT will tell me whether she has antibodies or not. I do ICT twice. First visit by she has not formed antibodies yet. I can prevent. ठीक है? Stuck? It is stuck? Just wait, it will come. Because network is same. It will come. So if it is negative, it means I have to give something so that antibodies don't form. What will I give? I will give an anti-D injection. I will give an anti-D injection so that she doesn't form any antibodies. Important is, when is it given? It is given at 28 weeks. But it is given only when my ICT is negative. Because if it is positive, it will not help. इसका काम है prevention. How will it help if antibodies have already formed? So if my ICT is negative, I will give anti-D at 28 weeks. Other than that, I will also give anti-D if there is any sensitizing event. Sensitizing event means anything that can lead to feto-maternal hemorrhage. Like, I did chordocentesis, I did amniocentesis, I did external kyphlic version, there is trauma to the abdomen, there is placenta previa bleeding, there is abruption. All that is sensitizing event. So every sensitizing event I have to cover with my anti-D so that antibodies don't form. Other than that, I will give it at 28 weeks. And last, I will also give it at delivery. So at these 3 times, anti-D is given. ठीक है? Okay? So if first of all, my ICT should be negative. When is ICT done? ICT is done at first visit and also repeated at 28 weeks. If the ICT is positive, prevention will not help. ICT negative, okay, I will give anti-D at 28 weeks. I will also give anti-D if there is any sensitizing event. I will also give anti-D after delivery, within 72 hours of delivery. How much is the dose? If I am giving it any time before 20 weeks, if I am giving it any time at less than 20 weeks, my dose is this, 150 mcg. Any sensitizing event at less than 20 weeks. After 20 weeks, which is after delivery at 28 weeks, after 20 weeks, my dose is double. So what I am giving anti-D. To whom? In patients where ICT is negative. At what gestation? If I am giving at less than 20 weeks due to any procedure, suppose there was threatened abortion, suppose there was trauma, suppose I did chorionic villus sampling. At this gestation, less than 20 weeks, I need small amount, 150 mcg. Anything happened after that, dose is 300. If no sensitizing event happened, then also I give it at 28 weeks. Then also I give it after delivery. After delivery is also a sensitizing event. And my dose is 300. This is prevention. Okay? I was not planning to treat. So anti-D dose in Rh negative mother is 300. Now if I talk about the treatment matlab Rh mein, if I did the ICT and ICT was positive, she has formed antibodies. Now these antibodies can anytime cross to the baby and cause anemia. Now I have to keep a check on baby, otherwise baby will develop anemia, baby can die. So now anti-D is not going to help. What will help? I will monitor the titer of antibodies. If my antibody titer is high, 1:16, this is the threshold. If it is a high titer, now baby can develop anemia. Now I will keep a very strict check for anemia of the baby. How can I check for fetal anemia? Baby ka, I can't take blood sample. 2 things. I'll check for hydrops and I'll check for middle cerebral artery blood flow. Whenever the baby develops anemia, the blood flow to the brain increase. because there is not enough oxygen. So blood flow to the most vital organ increase. So middle cerebral artery blood flow increase. It's an indirect sign. So if the titer cross the threshold, I will check for signs of anemia via middle cerebral artery. And as soon as I see the middle cerebral artery blood flow, which is peak systolic velocity, is more, or hydrops develops, I do fetal transfusion, intrauterine fetal transfusion. This is how I treat a patient who is ICT positive. There was a question. Fetal anemia is monitored by? Fetal anemia, in which pathology we will monitor? Which pathology baby will develop anemia? Not in maternal anemia. Maternal anemia mein baby never develops anemia. In RH incompatibility. And how do we monitor? Middle cerebral artery. If my middle cerebral artery ka peak systolic velocity is more than 1.5, then what will I do? I will do the intrauterine fetal transfusion. This is the whole RH incompatibility. One is prevention, that is to be done when ICT is negative. One is treatment, and which is done when ICT is positive. Okay. If she is ICT positive, will I give her anti-D after delivery? No. No role. No use. Anti-D has no role if ICT is positive. Okay? This was anti-RH incompatibility. Okay? Very less time left. Let's go to the labor. I think let's go to the labor. You want me to talk about pelvis and everything? Yes. Okay. Clear? Chalo. Now let's go to the labor straight away. Now, straight away the pelvis. Radiological assessment of pregnant women reveal an anteroposteriorly oval pelvis. What type of pelvis it is? See, pelvis, types of pelvis are based on the inlet. Pelvis is like a basin. It has an inlet, it has a cavity, it has an outlet. Based on the inlet, there are types of pelvis. Most common is where inlet is round, beautifully round. That is gynecoid. Most common type of pelvis in females. Some females has a oval pelvis like this. Next most common, it is anthropoid. Anthropoid. Like this one, oval shaped pelvis. Some women have anteriorly narrow pelvis. Posteriorly ऐसे dip है, it's a heart shaped. Anteriorly beaking है. It is android pelvis. And some women have a flat pelvis. It's a flat pelvis. Platyploid. Now what is the problem? Gynecoid pelvis is very spacious. And when the head enters into this pelvis, the occiput is in this transverse diameter here. Occiput is here in the transverse diameter. Either left occipitotransverse or right occipitotransverse. It is the best position. When it is anthropoid, see the space here is less. How can occiput take this diameter? So what does occiput do is, occiput takes a AP diameter. Occiput takes a AP diameter, it becomes occipitoposterior because this space is more. Because this space is more occipitoposterior, which results in a very prolonged delivery. So, anteroposteriorly oval pelvis is anthropoid, and if the question is asked, the pelvis that is associated with persistent OP position, occipitoposterior position, is anthropoid. Okay. Gynecoid pelvis में हमेशा occiput is transverse. Stuck हो रहा है बार बार, क्यों stuck हो रहा है? But are you sure anybody else is facing this issue that it is getting stuck? Because on my phone it is not getting stuck. If it is so, please let me know. What is this type of pelvis? Can you see the circle? Inlet circle, round, so beautiful, gynecoid. If anybody's video is getting stuck, please let me know. ठीक है, चलो. Presenting diameters. So ये तो हुआ pelvis का, ठीक है? This is about pelvis. Now presenting diameters of the fetal head. When the fetal head enters the pelvis, it can be flexed like this. It can be extended. So when it is flexed or extended, different diameters come. Now it is very easy to understand. When it is flexed, imagine it is bilkul flexed like this. What is the diameter which is coming? Occiput से नीचे, nape of neck, suboccipitobregmatic. This is the diameter which is coming, na? Suboccipitobregmatic. So in a fully flexed head, बिल्कुल flex है. What is the diameter? Not occiput, suboccipito. So it is suboccipitobregmatic, which is the best diameter, 9.5 centimeter. It is slightly extended. Now comes occipitofrontal. अगर फ्लेक्स कंप्लीटली नहीं है, थोड़ा एक्सटेंड, इफ इट इज स्लाइटली एक्सटेंडेड, नाउ इज ऑसिपिटोफ्रंटल. ठीक है, सो स्लाइटली एक्सटेंडेड, या फिर यू कैन राइट डाउन इट इज कंप्लीट फ्लेक्शन, इनकम्प्लीट फ्लेक्शन. फ्लेक्शन है बट इट इज इनकम्प्लीट. व्हेन इट इज इनकम्प्लीट फ्लेक्शन, इट इज ऑसिपिटोफ्रंटल. Not a bad diameter, but yes, a little more. Now extended, when the face is completely extended. So what is going into the pelvis? The face. When face is going into pelvis in complete extension, what is the diameter that is coming in face? This is mentum, submentobregmatic. This is the diameter, na? Tabhi face is the presenting part, submentobregmatic. So when the face is presenting part, it is submentobregmatic. खुद देखो, मेंटम है, उसके नीचे सबमेंटो एंड ब्रेगमा. दिस इज द फेस एंड दिस इज द डायमीटर, 9.5. Worst is partially extended. When it is partially extended, it is not fully extended, it is partially extended. When it is partially extended, the presenting part is this brow. It is not face, it is brow. Now what is the diameter? Mentovertical. This vertical is the highest point on the what we call it, on our vertex, highest point on the vertex. So mentovertical. So when partially extended, the presenting part is brow, this, and the diameter is mentovertical. This baby can't deliver. It's a huge diameter. ठीक है, सो यही याद रखना है. 4 डायमीटर्स: सबऑसिपिटोब्रेगमेटिक, ऑसिपिटोफ्रंटल, सबमेंटोब्रेगमेटिक, मेंटोवर्टिकल. 4 डायमीटर्स. प्रेजेंटिंग डायमीटर इन फेस, अब खुद सोचो, फेस है प्रेजेंटिंग डायमीटर. व्हाट इज द डायमीटर? इट इज सबमेंटोब्रेगमेटिक. ठीक है, ओके, क्लियर? मैनेजमेंट ऑफ लेबर में याद रखो 2 चीज़ें. वेन एवर इट इज़ लेटेंट फेज इज लेस देन 5 सेंटीमीटर. वेन एवर क्वेश्चन इज गिविंग यू लेटेंट फेज, शी इज लेस देन 5 सेंटीमीटर. प्रोलॉन्ग्ड लेटेंट फेज का ट्रीटमेंट होता है एक्सपेक्टेंट. यू डोंट डू एनीथिंग. पेशेंट इज 1 सेंटीमीटर, आफ्टर 4-5 hours शी इज 2 सेंटीमीटर. इट इज प्रोलॉन्ग. But will you manage? No. Latent phase is very slow. Friedman, the one who made your cervicograph, partogram, he suggested that prolonged latent phase has no effect on mother and fetus. So you do not do anything in prolonged latent phase. Nothing. ठीक है? But when it is active phase starts after 5 centimeter. So when it is prolonged, what is prolonged active phase? Prolonged active phase मतलब होता है rate of dilatation से देखते हैं. Rate of dilation should be more than 1.5 centimeter per hour in a multi-para, and it should be more than 1.2 centimeter per hour in a primipara. So if it is slow, now you intervene. So active phase may you manage, but latent phase may you don't manage. So if it is slow active phase, you augment. Augment का मतलब you are pushing. You start oxytocin. You do ARM. You check for any pelvic insufficiency. You are pushing the labor. That is augmentation. Induction क्या होता है? Induction मतलब she is not in labor. She is not in labor. You are starting the labor. Patient hypertensive है, she is not in labor, but it is severe hypertension. You start the labor, that is induction. Patient already she is in labor, but it is slow, that is augmentation. Why I'm telling you that? Dekho question. Primea gravida comes at 1 p.m. for 5 centimeter. She's in active phase. At 4 p.m. after 3 hours, she is only 1 centimeter dilated. Is she slow? Yes. What is the next step? Wait for spontaneous? No. Induce. Induce hota hai when she is not in labor, you are starting it. Hypertensive or diabetic, you are starting labor. It is not induction, it is augmentation. So these are two different terms. So don't get confused. There people got confused whether it is induction or augmentation. They look similar, they are not. Method to induce, method to augment are same. Similar methods are used, but the terminologies are different. Okay? Which of the following is end of the first stage? So first stage is from the pain till 10 centimeter. 10 सेंटीमीटर के बाद यानी फुल डायलेटेशन के बाद स्टार्ट होता है सेकेंड स्टेज. So which of the following is end of the first stage? Cervix is dilated 10 centimeter. It is the end of first stage. है ना? Second stage, when the mother is pushing the baby out. There are few things which are done to prevent perineal trauma. Many times asked. What should be done to prevent perineal trauma? 3 things given by WHO. Hands on. This is hands on. One hand on perineum, with other hand you flex the head. Flexed head has the smallest diameter. So hands on say you are flexing the head. लग गया इंजेक्शन लग गया कोई प्रॉब्लम तो नहीं. So when you are flexing the head, that is hands on. You are protecting the perineum and flexing the head. Second is warm compresses. You keep applying warm cloth on the perineum during labor. It leads to muscle softening. And third is massage of the perineum. All these 3 methods are given by WHO, not by me. So these 3 prevent perineal tear. Massage करते रहो, keep massaging the perineum in between contractions. Apply warm cloth and hands on. Ritgen's maneuver is not for perineal protection. This is Ritgen's maneuver, where you are pulling the baby out. You are putting one hand on the chin of the baby, other hand on the head, and you are pulling the baby out. It is done in exhausted mother. I have taken this page from the Williams. If the expulsive efforts, the efforts of mother are inadequate or expedited delivery is needed, you need a fast delivery, Ritgen maneuver is used. Okay? With maneuver, gloved finger grasp the chin and exert upward pressure between contraction. Okay? Although expeditious, although fast, this maneuver does not alter the anal sphincter injury rates, obstetric anal sphincter injury rates. So Ritgen maneuver is not for perineal protection. For perineal protection, WHO has given you hands-on technique. This is different. Hands-on is different. Ritgen's is different. Ritgen's का काम है expedite the second stage. I have taken this from latest Williams. Ritgen's में you pull the baby out. When the mother is not pushing, you pull it out. Perineal protection के लिए WHO has given 3. Don't add 4th from your side. They have not given Ritgen's. Hands-on for flexing the head, warm compresses and massage. Okay? Okay? So it is not preventing perineal trauma. They have written it has no rate effect on the anal sphincter injury. Okay? I'll just send you the PDF, beta. Don't worry, we'll just finish the class and I'll send you the PDF. Okay? So this is about labor, active management of third stage of labor. Yes. So this was first and second stage kar liya. What is third stage of labor? Stage of placental separation. We will do the active management always, because the main reason for doing active management of third stage of labor is preventing PPH. It prevents PPH by 60%. So in whom AMTSL done? In everyone. 3 steps given by WHO. Uterotonics. Uterotonics is given immediately after delivery of baby. Immediately. And what is the uterotonic of choice? It is oxytocin. If IV cannula is there, IV is the first choice. If IV cannula is not there, then you give IM. But oxytocin is the choice. Either IV or IM, 10 units. If cannula is there, IV is the choice. If cannula not there, IM. ठीक है. इसके अलावा you can, if oxytocin is not available, then you can give misoprost. You can also give carbitocin. So misoprost and carbitocin are the second choices for prevention. I am preventing PPH. I am not treating it. AMTSL में आप PPH, you are preventing it. So prevention we have oxytocin, misoprost, carbitocin. ठीक है. Third thing is controlled cord traction. ठीक है. Keep one hand on the uterus, one hand on the cord. Maintain traction. Don't pull. If you pull, it will be inversion. Just maintain the traction. Controlled cord traction. And third is uterine massage. In fact, you call it uterine. Instead of massage, the better term used by WHO is uterine tone assessment. You assess the tone repeatedly. Uterine tone assessment. So 3 steps in AMTSL are uterotonics, controlled cord traction, and uterine tone assessment. Delayed cord clamping is done in every barn, but it is not the part of AMTSL. AMTSL में 3 things हैं for preventing PPH. Cord clamping has nothing to do with PPH. Delayed cord clamping is done to prevent fetal anemia. Whatever blood is there in the cord, it is transferred to the baby. So delayed cord clamping is done in all the patient. Is it part of AMTSL? No. So delayed cord clamping is done in all except the only contraindications for delayed cord clamping is not RH, not HIV, when the baby need resuscitation. Even in HIV, even in diabetes, even in RH, you do delayed cord clamping. Only time you don't do delayed cord clamping, means cord clamped after 1 minute, is when the baby needs to be transferred to the NICU, when the baby need resuscitation. ठीक है? Okay, this is the only indication for early cord clamping. Otherwise, in all of the patients, you do delayed. Early cord clamping is performed in eclampsia, preterm, RH. No, when you need resuscitation. Otherwise, in everyone, we do delayed cord clamping. Okay? Now, this is finished. Let me go to the maneuvers. You have taken a promise that I'll do the maneuvers. This is I was otherwise also planning to do maneuver. There was nothing you had to worry about. Identify the maneuver. I've just explained you this one. You are putting one hand on chin, one on head, and you're pulling the baby out. Ridgens maneuver. What are other maneuvers? See, सारे maneuvers are there in breech baby. Breech baby को समझो. Breech baby में what we do is assisted breech delivery. Assisted matlab you assist at every step. So imagine a breech baby. When the breech baby comes, first what comes? Buttocks. Then comes the legs. Many times the legs, if the legs are flexed, so if the legs are like that, this is the buttock and this is the leg. If the legs are flexed, the legs will come out. If it is the legs are extended, it's a frank breech. You need maneuver. Pinard's maneuver. So this is the assistance that is needed. That is why we call it assisted breech. You need to assist the baby to deliver. Pinard maneuver is done in case of frank breech. You go to the leg, you pin the, suppose this is the leg, you go via your finger, you pin the popliteal fossa. When you pin the popliteal fossa, it will flex, leg will flex. As it flex, catch it, bring it out. Pin the popliteal fossa, Pinard's maneuver. Done for extended leg. Suppose legs have come out. Now hands are extended. We call it nuchal arms. If nuchal arms are there, how to bring it out? Lovset maneuver. You rotate the baby and take the arms out. So Lovset maneuver is done for extended arms. Pinard's is done for extended legs. Now everything has come out. Head is inside. Marucci semilvit maneuver. Marucci semilvit is done when your one hand is below the baby and with other you flex the baby hand and bring it out. Marucci semilvit is done for after coming head. Bird Marshall. Now obsolete, but yes, for coming after coming head also you used to hold the baby with feet and rotate the baby on maternal abdomen. It is Bird Marshall. Now you not do it because it used to cause the extension injuries in the neck. Bird Marshall. Another way of bringing the head out is via What is this? Piper forceps, curved Piper forceps. ठीक है? Generally the ratio is 80-20, obs and gynae. The ratio is 80-20, it can be 70-30, but 70 is obstetrics, 30 is gynae. ठीक है? So Pinard's maneuver, Lovset maneuver, Marucci Semmelweis, Bern Marshall and Piper forceps. ठीक है? Okay, maneuvers. एक हम देख लेते हैं टाइप्स ऑफ फॉर्सेप्स. सी forceps delivery is done to bring out the second stage of delivery. To shorten the second stage of labor, you do forceps delivery. There are 3 places where forceps is applied. Outlet forceps. Outlet forceps is applied when the baby is just at perineum, about to come. So when you are applying a forceps at outlet, baby is just at perineum, you need a small forceps and you need a small force. So that is, for that you need an outlet forceps. When the head is just at perineum, you can see the head without separating labia. When the baby is above the perineum, head is below +2 station but above the pelvic floor, it is low forceps. And third is the head is engaged, that is the prerequisite, head has to be engaged but it is above +2, mid forceps. Now different places need different forceps. That is why we have different types. A small forceps which needs, where we can apply only small force, outlet forceps. The name Wrigley's. Another Indian one is Das forceps. Wrigley's and Das are outlet forceps. When you see a long forceps, it is for mid cavity forceps. It is Simpson forceps. Simpson is just like Wrigley's. Only thing is the shanks are longer. So you can go inside and you can apply more force. It is Simpson. Third forceps looks very different from other two. When the other two are closed, the handles are opposed. And this is the shank. And the shanks are far away. Can you see this forceps? When it is locked, handles are away but the shanks are opposed. It is reverse of other two. It is for rotation. It is keel end forceps. When you lock them, handles stay away but the shanks are opposed. This is keel end forceps. Outlet, Wrigley Das, Simpson, keel end. And one we have just done, the curved one, Piper forceps. Piper forceps is very curved. So because baby's body has to hang, na? Baby ki body has to hang here. कहाँ गया? Because baby's body has to hang on that forceps. That is why the body of this forceps is curved. It is Piper forceps. So learn to identify the forceps because there has been questions. What is the other name for outlet forceps? Wrigley's and Das. I think now they have given very close option. Wrigley's and Das are both the outlet forceps. But more scientific is Wrigley's. This is again a outlet forceps, है ना, छोटा सा outlet forceps. ठीक है? Now vacuum. A little bit about vacuum. Again about forceps. Outlet forceps are applied with which of the following stations? Outlet is done when a head is on the perineum. Okay, so a lot of questions are there on the forceps. Vacuum. Another instrumental delivery is vacuum. Important thing. Vacuum is a very good instrument. It causes less trauma to the mother. Forceps cause a lot of trauma to the mother. But vacuum has certain contraindications. You can't apply vacuum in a preterm baby. You just can't. And you can't apply vacuum in face presentation. You can apply forceps in a face presentation. But vacuum on face can't apply. In preterm baby less than 34 weeks, you can't apply. It will result in cephal hematoma. Okay? So these are the two contraindications for vacuum. Now where is vacuum applied on the head? It has to be applied on a particular point. At the flexion point. Flexion point is somewhere when you apply it, head will flex. And when the head flex, smallest diameter comes, baby come out. The flexion point lies where ये occiput है, this is occiput, this is the posterior fontanelle, just 3 centimeter in front of it. the center of your cup should be on the flexion point, which is 3 centimeter in front of the posterior fontanelle. When you apply this way, the rim of your cup is on the fontanelle. When you apply the cup on the flexion point, when the center of your cup is on the flexion point, the rim is on the fontanelle. And where is this flexion point? 3 centimeter ahead of the posterior fontanelle. Okay? So where it is? 3 centimeter behind anterior fontanelle? No. On posterior fontanelle? No. The rim is on the posterior fontanelle. The flexion point is it is anterior to posterior fontanelle. Okay? Now I think we should finish. Few topics are left. I'll share the PDF. You will find them here. Few topics are left, like maneuvers for shoulder dystocia and inversion, and also very few topics. I've just made the summary. And also what is left is little bit about lochia, the sequence of lochia, the sequence of mammogenesis, that is also left. Okay? Mammogenesis, lactogenesis, what it is. It's just 10 minutes topics are left. I'll just share the PDF. Please read this PDF and you will remember everything. Okay? Partogram. Okay. My class has got postponed now. You are asking me to take more. But yeah, I understand. But it's your exam. It's one of the most important thing. I was also panicked when I had my exam. Partogram. Important points about partogram. When is partogram plotting started? In active phase. So when is it started? At 5 centimeter. Where is it started? Where is the first mark given? First mark. Suppose patient comes to me when she is 7 centimeter. Where will be the first mark given? On the alert line. My first mark will be 7 here. If you can see here. Yes. Can you see 7 here? On the alert line. Here the first mark. I'll start the plotting from here. On the alert line. So where is the first mark given? The first mark is given on the alert line. Whatever said here. And from here I'll start my plotting. Suppose she comes at 4 p.m. Okay? So important thing, when is it started? It is started at active phase. It is started at 5 centimeter. The first plot is on the alert line. Second, how frequently you plot? Every 4 hours. Not compulsory, but yes, every 4 hours the PV is done and plotting is done. Third, how much is the small box? The small box shows you the 30 minutes. See, come here. Big box shows you 1 hour. Can you see the big box? It is 1 hour. इसके ऊपर small box is 30 minutes. So each small box, each big box is 1 hour and the small box is 30 minutes. Okay? According to partogram, what is the rate of dilatation? According to the partogram, the rate of dilatation according to partogram is 1 centimeter per hour. That is what alert line shows. 1 centimeter per hour. See, 4, 5, 6, 1 centimeter per hour. Your first plot is on alert. If your progress is slow, it will immediately cross the alert line. If your progress is not 1 centimeter, it will immediately cross the alert line. As it crosses the alert line, what will you do? You will become alert. You will transfer her to a tertiary care center. You will not do cesarean. You will become alert. You transfer her to tertiary care center. You start oxytocin if the contractions are bad. And you assess the pelvic size. You assess for cephalopelvic disproportion. And you continue the oxytocin. After 4 hours, if the progress is still slow, it will touch the action line. As it touches the action line, deliver. If she is fully dilated, apply an instrument. If she is not fully dilated, never apply instrument. Instrument is applied only when the patient is fully dilated and the head has crossed the 0 station. So if head is above and she is not fully dilated, answer is cesarean. If she is fully dilated, answer is instrumental delivery. Only when she touched the action line. Alert and action line are separated by 4 hours. You do PV every 4 hours, no? So they are separated by 4 hours. Okay? How to plot the contraction? How partogram will show me the contractions? Partogram has these boxes for contraction, which I don't have here. It has boxes for contraction. So the number of ऐसे होते हैं. It has number of boxes for contraction. So the number of boxes which are colored show the contraction. If the 3 boxes are colored like this, It means 3 contraction in 10 minutes. 4 are colored, 4 contractions in 10 minutes. Intensity of contraction, अगर डॉट डॉट है weak contraction. Lines है question में, it is moderate. If it is completely shaded, it doesn't need to be completely dark, but if it is completely shaded, it is a good contraction. 4 good contraction in 10 minutes. ठीक है? Alert line is starting at 4 centimeter. पहले plotting used to start at 4, that is why it is starting at 4 centimeter. पुराने पार्टोग्राम में we used to start the plotting at 4 centimeter. That is why it is starting from 4 centimeter. Okay? Right? Chalo. Everyone, thank you so much for your time. And I'll talk to the team in case we take another 1.5 hour is sufficient for gynecology. In case we can take, we will definitely arrange for one class for 1.5 hour. है ना? We'll definitely try doing that. ठीक है? Okay? Bye bye everyone. In case you have a question, you know my Instagram channel, Dr. Shefali Tyagi. You can always ask questions on that Instagram channel. In case I take a class of my own, I will post that on my Instagram channel. In case that class is not taken by the team, I'll take 1 hour class of my own on YouTube and I'll post that on the channel. Okay? Bye bye everyone. I'm just sending you the PDF. Okay?